Good afternoon, everybody. We continue our agenda with a topic that has great expectation among the audience. We're going to talk about the UN Resolution on Rare Diseases.
A los panelistas que nos acompañan, Durheim Wong Rieger, ¿ya? Presidente y CEO de la Organización Canadiense de Enfermedades Raras y miembro del board de
He's a member of the Rare Disease International Board. We have Dr. Natalia Messina, Director for Special High-Cost Drugs, the Ministry of Health in Argentina. Germán Escobar,
Viceministro de Salud y Protección Social de Colombia. Y por último, el doctor Gustavo Méndez, exdirector general de Medicamentos y Productos Biológicos en la Agencia Nacional de Vigilancia Sanitaria en Anvisa, en Brasil. Bienvenidos a todos y bueno.
Welcome everybody. We have a technical issue here with Durheim. Can you hear us, Durheim? So the first question is for you. I would like for you to tell us what are the main parts of the UN resolution that was published over a year ago. No, el micrófono, por favor.
Is this working? Okay. The UN resolution is something we worked for many years because we really wanted to, number one, get rare diseases established as a global issue. I mean, recognizing that obviously we know that it is a global, these are global conditions, but the recognition of it as a public health issue at a global level has never been done. So that was really important, get acknowledgement. But within it was more important, and that is to say, first and foremost, as you've been talking about today, it's not just a medical condition. It is far more than just affecting people in terms of their physical health. More than, obviously, mental health, but some of the other issues, right? The social impact. Therefore, living with a rare disease, patients and families suffer tremendous social impacts in terms of being able to participate, in terms of issues around equity, in terms of issues of stigma, in terms of actually access then economically to the workplace, access to education, but as you also talked about today, the disproportionate impact on the whole family. And isn't just the same as, and this was kind of the big challenge we had, why isn't it covered already under disabilities? If we have resolutions on disabilities, how come that's not enough? If we have resolutions already on children, how come that's not enough? And the answer is not enough because even within each one of those categories, if you have a rare disease, you're even further behind. And if there are programs and if there is in fact support for education or for economics, again, if you have a rare disease that is not necessarily recognized, you're also going to be further behind. But the biggest thing what we recognize, of course, is that with rare diseases, getting access to a diagnosis, getting access to a specialist is really challenging. And without those, you do not actually get any of the other benefits. So it's recognizing we start with the medical and the diagnostics, but the disproportionate impact runs all the way through. So the resolution, hopefully, because all the 194 countries signed on to it, they said, we will absolutely support initiatives that can help us in terms of recognizing the disadvantages there. For us, it's not that they're going to do anything for us, but it gives us the opportunity to have things done if we push them forward.
Fantástico, sí, generar un poquito más de contexto y aplicabilidad dentro de
Yes, to provide you a bit of context, I would like now to move on to Latin America. Dr. Messina and Dr. Escobar can give us another view on how to bring it down to Latin America in terms of its concrete implementation. Good afternoon. First of all, I would like to thank you for inviting me. A big thank you to the organizers. And I think that your question is a very important one because if resolutions are not implemented, they will never come alive. Argentina was one of the countries that supported this resolution, and we did a lot of work there. But if we do not implement them in our country, at the very least, we are not being coherent. The reality in Argentina, well, I'm going to talk about how it was worked upon and why. First of all, it was a resolution that was driven by three countries, Spain, Qatar, and Brazil, a Latin American country. And it was through patient associations in these different countries, obviously with the push of rare diseases and errores, that came to each competent public body to knock on our doors and told us that we should support this project. And what happened in Argentina is what happened is that when they asked us for a report, we saw that they were along very similar lines that we were working on. So we not only accompanied it and supported it, but also we celebrated it, because when we see that we can support something at the global level and even more so at the regional level, creating bonds, stronger bonds within Latin America. Well, in fact, it was between August and December the resolution was moved through. I won't talk about the resolution itself because Durham explained it very well, but I just wanted to tell you that there are main lines that that resolution entails, and I want to highlight. And by doing so, I can tell you a bit more about our experience in Argentina. This is a very important resolution because its outlook is beyond the health aspect. It has a component that talks about a comprehensive patient care, and it has a very deep look into the social determinants and the situations of vulnerability that need to be taken into account for each patient. As a general strategy, Argentina, well, we have a law on rare diseases, which is very important because it's a big umbrella for us. It has a definition that is very specific, but it happens to be different than in our brother countries. And we heard that in Argentina we have an updated list of rare diseases that includes more than 5,800. That is so because our law says that diseases that have a prevalence equal or greater than 1 in 2,000 are rare diseases. This is the difference between other countries. It's not that in other countries there are more or less diseases. No, this is not a subjective decision. When we establish in law how to frame or how to define a rare disease, and you determine it according to an index of prevalence, you'll get a similar number, because what happens in our region is that we take or we import our prevalence. We do not even take it from our own countries because we lack databases. So this morning when we heard that in a country there are 10,000, another 1,000, but in Argentina we estimate that there are 3.5 million Argentines that have a rare disease, and we haven't identified them. We do not know where they live, where they are being taken care of. And so that's why we started to work on it. We started to take steps that are very important steps that do not involve resources. Yes, human resource, but what you need is political will. What cannot be lacking is political will to be able to tackle the issue of public policy, and especially public policy focused on comprehensive care for rare diseases. So we developed a series of strategies that are prioritized according to our needs. For example, the creation of a national registry. It's a registry that is online now. It is a health information system, and healthcare professionals can log on and upload information about their patients with a diagnosis. And this is how we've started to create our own information, Argentinian information, because another, even so, even if a disease has a different pathology in a neighboring country, what we know is that we cannot continue to import prevalences from other countries that have nothing to do with us. We've done so because it's the only tool at our disposal, but that is why we've started to create our own registry. Then what we started to do was to identify prevalences on a list. Our first list came out in 2021, and we updated it in January 2022 according to the Orphanet France. We are adhered to this organization, and there's a permanent collaboration scheme ongoing that provides us with a lot of necessary information for us to do our work. And the reality is that all of these diseases, well, if a patient is listed there, he can look up his own profile on the website with just by the three first letters of the disease. And for example, we have 24 provinces, and we have a provincial reference or contact point, which is the contact person that works to implement policy at the local level. We also started to work on primary care to demystify the pathology and around these diseases, and we've started to work hard on the provinces with this. We are part of a network that is driven by Elise Saint Laurent and is creating laboratories to do genome sequencing in several regions of the country and thereby create a network. There are many actions that, as I said, many do not require a lot of budgets, but they do require political will. Yet there are others that when you start to consolidate these actions and these public policies and you start to see results, you start to detect real needs. You cannot suggest to the decision maker or to the Ministry of Finance or Treasury Department money to implement a public policy if you do not have adequate information about your needs. And this is part of the essential actions. We need to work with patients' associations. This is key. They cannot be not having a seat at the table. We also work with an honorary steering committee, which is made up of experts, patients' associations, and representatives of the Ministry of Health, where we discuss these action lines and the work to be done. Well, at the regional level, I believe that at the minimum, we need to create a single definition for rare diseases. That's the minimum. I think that the first thing that we need to understand is the spirit of the resolution. I think that Durjan created a very good summary, and this spirit was born out of understanding that it is a sine qua non condition to provide access to care for rare diseases, but that is not the only condition to create comprehensive care system for rare diseases. We need the convergence of other sectors that are as important: education, culture, entertainment, security, and labor force support. So implementing that resolution entails a series of important challenges that require intersector work. And there's no linear path that we could follow, but there are a series of minimum conditions that we need. Number one, Argentina just told us we need information, and that information starts by adequately identifying our patients, but the information systems need to evolve to understand other variables that are part of the patient's profile, social, demographic information, that it is very complex. Number two, it has to do with healthcare, which is accessibility and coverage. And I think that the resolution is very explicit and gives countries a big mandate, which is by 2030, in the framework of universal coverage, RD patients cannot be left behind. And the countries need to guarantee a way so that they can provide care for them and also bring in technologies. This is a discussion that we need to have in each of our countries. Some are lagging, others not so much in terms of access. And what is going to happen is that the governments are surely going to have to find mechanisms for financing mechanisms that are different to the ones that we've been using so far to alleviate this fiscal pressure brought in by these new technologies. An example is the pharmaceutical industry. They will have to come to sit at the table and talk about the new realities. For example, access to services through a shared risk scheme. So to sum up, number two is to secure financing and availability from the healthcare aspect. Number three, once we have these fundamental conditions, we need to move into the intersectoral domain. I insist it's not a linear one, two, three steps, but there are contact points that need to be dealt with. For example, this intersector aspect is the least explored among our countries. In the case of Colombia, Colombia has a 10-year health plan that looks at the problem from the intersectoral point of view. We had the last version of the health plan published last year. Due to a change in administration, that plan right now is being reviewed, and we have great expectations that it be relaunched soon, and the intersector work then depends on the convergence of other sectors to be able to achieve our objective, which is well-being. And this objective is achieved through, number one, information, number two, adequate healthcare, but also reinsertion into the labor force, opportunities for education, preferential support in socioeconomic terms. And I think that the resolution recognizes that this is a poverty trap where patients and caregivers are impacted because they cannot bring further income into the home. All of these policies need to be harmonized and be patient-centered. That's the biggest challenge. How do we implement this? Well, you need a mechanism for communication to bring down this policy to the local level with an intersectoral point of view, guaranteeing effective healthcare and coverage as the resolution demands. Yes, tomorrow we will have another panel that has generated great expectations, which is on financing. We will talk about this tomorrow. Durham, what are some of the challenges that we've seen. I know that the resolution was published just under a year ago or over a year ago, and there's not much we could say in terms of evidence, but from what you've seen, what are the challenges at the global level? And then I would like to ask Dr. Mendes, what are the challenges that he sees in terms of Brazil, and if you could give a regional perspective as well, please.
So the biggest challenge that we see right now with the UN resolution was something we did not anticipate, and that is we have to come back and have it renewed. A UN resolution only holds for 2 years unless you get it renewed. And to get it renewed, we have to come back and do exactly what you're talking about here. What did we do with that resolution? So we gave you a resolution. We packed it with all the things you asked for. Did it make a difference? Did it make an impact? What were the kinds of changes that you were able to make happen? And you know what? We can't do that at the RDI urologist level. We can't even do it at the national level. We can only do it at the level of everybody here. And this is why this conference actually is so very important, because what we're hearing are all the ways in which you have been able to leverage what's in that resolution. We've been hearing all the ways in which you're connecting together in order to be able to expand kind of what the expertise in one region, to be able to share it, to be able to kind of bring together that community. This, to me, is going to be one of those things that we're hoping to capture and to use to go back to the UN and say, see, here's what can happen, and here's how the whole environment changes. I heard something really exciting at one of the earlier panels that said, we think rare diseases is going to show the world how healthcare should be done, how disease management should be done. And that's not a trivial point. I think it's very true. Because, and at some point I'd love to talk to you about what came out of the resolution for us at RDI and in our negotiations with the WHO was we got a memorandum of understanding with the WHO on the strength of the fact that we got a UN resolution. In fact, it was the first UN resolution on universal health coverage. We got a very tiny little phrase in there that recognized rare diseases was a disadvantaged population, and that as countries are bringing in universal health coverage, they must, in fact, include explicitly rare diseases. That was the opening for us to make sure that as countries are evolving in terms of their ability to provide healthcare services from prevention all the way through, that we have the space for rare diseases. And it truly is the meaning that, leave no one behind. And I think we've heard them say, if you're leaving behind rare diseases, then you're not living up to the obligation. But it's still up to us to be able to do that. But we have with the WHO now, with RDI, Rare Disease International, we have had for the last 3 years a memorandum of understanding. And within that was one very important issue. They came back and said, can you give us a global definition of rare diseases? And we came back and said, we can't do that. There's no such thing. We can give you a global description of rare diseases, and we can work with all of the countries and groups to actually say, what is it that makes rare diseases unique? They're small patient populations, usually severe, highly progressive, debilitating, life-threatening, difficult to diagnose, have few treatments. There's a whole host of diseases that this is what we're trying to fix. It has nothing to do with a number, right? And it doesn't really matter at the end of the day. We have questions that's like, okay, if you have more people you've identified, does it still remain a rare disease? Is a rare cancer a rare disease? It's not a question. Does it fit the description? So this is a big step forward, and WHO seems to be happy. We're going to be working with it. Second thing we negotiated with them, though, is, in fact, the creation of a global rare disease network. And it's kind of what you were talking about today. And I absolutely was fascinated because I will have to say, honestly, within 3 years of consultations, we have not drilled down enough to understand what's on the ground. And what you've done here is actually create your own networks that work across different service areas, work across different, in terms of newborn screening, diagnostics, service, the ability to do reference networks where you can actually contact, appropriate specialists who might be able to support. That's the whole idea. Now, it needs to be more formalized, it needs to be sufficiently financed, it needs to be standardized in many respects, but that's what we've been working with the WHO to say in this in this UN resolution. What it means is that it's a global public health issue. We need to work globally in order to address it. But to do that, we need to work regionally. And in order to work regionally, we need to work nationally. In order to work nationally, we need to work locally, and all of that has to fit together. So I'm very excited by what we're seeing here. I would have to say what I heard today as models is not like anything I've seen elsewhere. So you're forging a different model that really is going to help us in terms of being able to identify, what is going to be taking place here. And then the third thing that we've been working on, and actually was revised out of the MOU because it's such important things, and that is the Global Access Program. Rare diseases only became defined by orphan drug legislation. It has nothing to do with real numbers, right? It came about because in the US and in Europe, they said, these are a group of diseases which aren't getting any access and treatment because nobody's doing development, because it costs too much. And so that's where the definition of a rare disease comes from, is in the orphan drug legislation. The challenge we've got now is to say, nobody thought when we introduced orphan drug legislation, people say, oh, good, we now have incentives to create therapies for rare diseases, going from 10 therapies, 25 therapies, to now well over 700 approved therapies, to say, and is anybody going to get them? We did not talk about the other end of it. Who's going to actually make them accessible? Who's going to ensure that they're going to be affordable? Who's going to make sure that patients across the globe are going to get them? We didn't talk about any of that. All we talked about, let's create new therapies. Let's create new diagnoses. So now the big challenge is we've got a lot of these. I'll give you a quick statistic. We heard from an IQVIA study, 10% of patients in developed countries who could be eligible for rare disease treatment actually get that treatment. Across the globe, less than 1% of patients who are eligible for treatment get that treatment. Now that's a tragedy, because you think about all the money that went into the research and development of it, and nobody's getting these. I also kind of go back to companies sometimes and say, look, you're pricing your medicines on the basis that you're going to get maybe 10% of the population. What if I gave you 100%? What if you actually could get financing for 100%? How much you want to charge us now? I think we need to start thinking differently and giving that entire population there and saying, what are we going to do there? So this is what we've been doing with the UN resolution to try to drill it down into policies. And the WHO has been very strong. We have a renewal of our MOU coming up. We're just finishing up. We're going to another 3 years. We're hoping to have a WHO resolution on rare diseases for 2024, which is even more important, because a country that signs on to a WHO resolution is signing on to implement. They're just not signing on to say, that's a good idea, we endorse you. They're saying, okay, here are the metrics, here are the accountability. So we need what you're doing here to help us make that case. And we need exactly what you're talking about. We need Argentina, we need Brazil, we need Colombia, we need Chile, we need Peru, we need Ecuador to come back and say, we want this to happen. It's giving us benefits. Here's how it's benefiting us, and we need to have that next level. So I thank you very much for doing this and for giving us the opportunity to see some of that up close.
Gracias, Dor.
Thank you, Durham. I still have many questions, especially in terms of the definition that Durham talked about. You said that you cannot implement a universal definition. I would like to know what our panelists think about this. What do you think about a universal definition? First of all, thank you for inviting me to talk about our experience in Brazil. But I'd like to focus on this idea that rare diseases can show us how the healthcare of the future might be. Yes, because we have specialized therapies, more individualized therapies, and we need to see how we can guarantee access to these. And we do need to think about conceptualizing, because we need something that understands the local realities and is according to their resources. Well, Brazil was one of the countries that worked actively on the UN resolution. Because Brazil has a lot of experience with working with the UN. I've had the opportunities to bring to the table different stakeholders to guarantee that we have policies that guarantee access, but we know that there are many challenges. there are many challenges in Brazil. That is a very big country, very diverse country, and we know that we do not have infinite resources. We have the opportunity. I want to talk about two paragraphs, which is, or two sides of, which is the health care regulation. In Colombia, we have INVIMA and MATE that are key stakeholders that need to be involved from the beginning because they are the agencies that can differentiate the products, tell us who should get the benefits. So I think that we need them as active participants here to discuss and contribute in conversations about access. I have experience as a cost benefit evaluator at Conitec. Yes, it is a big challenge because we need to think about it the same way as we did for another product. Nothing would be cost effective because these drugs are difficult to develop, costly, because in terms of amounts of patients, we do not have many patients. I think that the resolution helped us to think globally, not only in our region. We need to change the tools to evaluate cost benefit. We need to look at the industry not only as something that is profit driven, we also need to see the industry as an ally that need and the partner that needs to negotiate prices and the risks.
Because in many cases, I'm focusing on therapies, and therapies are approved as phase two studies, studies in which you still have to monitor in a frequent way and close monitoring to those that are generated. And it is not fair that many times all the government assume that risks, and that is the industry that charges a lot of money, so you don't participate of the strategy and the negotiation related to the generation of data. But I think the resolution like that makes makes you think in a global way that we have these challenges and we need to think this joint strategies in different realities, of course. But I think that in the pandemic showed that for us there is no possibility to think in a wrong way. We have to think in health and globally. That resolution that way gave the opportunity for us to join and think about this. Thank you, Dr. Mendez. So, Mariana, I would like to know what do you think on how can we make to generate common strategies in Latin America? Well, first thing that I consider, and I think we're doing it now, is um, collaborating among each of the countries and listening to all the experiences, the people that have been working in the field of rare diseases as you to apply the best practices, best things that work in different countries and close the gaps that are already there in the other countries. Um, I would like to go back to the topic related to the definition about Dorhan and Dr. Messina said that definitions that we have in these moments are based on prevalences. What problems do that what are the limitations basically of this definition? And you three have been government, so what benefit or prospect could have definition or a unified definition for all the region? Well, let's see. It is important to define that when we were able to give the first step, well, when it happens in all the countries in the world, I think, um, to be able to identify and being able to give a different umbrella for the situations that a patient with a rare disease can have, um, and that's why there is a law, and we can frame them in any type of health law or in any type of, let's say, within any medical program with a regular assistance. But we all agree that these are not diseases like any other disease, not because they are dangerous or difficult, but they are different. They have common problems, difficult paths to walk through, and it is difficult to identify reference centers in which we are working on. Our specialists are working in that. They are ultra rare illnesses or diseases that you have a single specialist for a country with 4 million inhabitants that has an extension like Brazil or Argentina. So the first step can define, let's say, now, and I think that prevalence is short. Prevalence is short. And in the same way, Argentina is a country in which it is a wider umbrella and more than the others, but I think it is short still. However, when I speak about a definition, a common definition, countries, at least in Latin America, should have to talk. And Argentina, it's a country that receives patients from other countries that are close to us. So permanently, we are working with the same language. And we should do that. And we should have a cooperation in many other things. Let's say, of the tools that we have nowadays with from the pandemic to start working with telemedicine, televisits, and find and the evaluation of a patient and strategies. And with this type of pathologies, um, we should improve in these strategies that we should take to the future. And we are not going to talk about financing, about access, because we're going to discuss that tomorrow. But at least we should know that 5%, this is not a lie, only 5% of the orphan illnesses have medical treatment. The rest of them have a more biggest difficulty. Access to diagnosis first, then access to basic treatment that are not a high price or ultra high price or any other thing. And of course, having a life with the same conditions as any other. So I think the resolution from the UN framed in the objectives of sustainable development consider other situations, health and whatever you say. I think it is valid. The view is different. It's human rights. Hendy, do you have any comment?
Maybe a wrong impression I gave. There is a core definition that we started before the description, and that is we still use, at the very bottom, 1 in 2,000. So, but as you can imagine, that really doesn't fit with the U.S. definition any longer. And quite frankly, it's almost ironic. The disease which actually prompted the Orphan Drug Act was driven by Abby Myers, who was the president of the National Organization for Rare Diseases at that time. She had a son who had Tourette's, and there was a drug that was being developed, and at some point the company says no longer cost effective for us to develop this drug. It's not working for the bigger disease that we were really developing for, so we stopped clinical trials. That was the big tip-off. If we look at the numbers, the prevalence of Tourette's, it's no longer a rare disease. So the disease that prompted the orphan drug legislation is no longer a rare disease in strict terms. Multiple sclerosis in some countries is a rare disease, it's not in others. I mean, that's stupid. You know, we should not be cribbling over numbers. I'll give you a definition that I like a lot, and it's one that you're struggling with as well. Because most of us as countries, once we start to talk about a definition of rare diseases, and in Canada, we're just implementing our first national rare disease strategy, is that we're not just thinking about what are the incentives we give for research and development to companies in order to develop medicines. That was easy compared to what are all the kinds of services that we need to be able to make available to the patients. This is what we're struggling with. And I think that's a really different kind of a question. And I'm happy that we're going to be talking about it tomorrow when we're talking about it. But I think we've been looking at it backwards. All of this is still an investment. What we said is we invest in research and development, we get something out. We're now investing in access for patients. And we will get a great deal back out. And we need to start thinking about it in exactly that way. But it is challenging. I'll tell you one country's definition that I like a lot, and that's Taiwan. Taiwan had started off with a definition like 35 rare diseases, and then they went to like 50. Then they went to 180. I think they have 250. Do you know what a rare disease in Taiwan is? It's whatever the government says it is. So you make an application, they review the application, and the government says, okay, but you know what's the benefit of it? Once you get your disease designated as a rare disease, you get a whole host of healthcare, social, economic benefits that come along with it, because that's the obligation. And I think that's what we're trying to do here. And that's what you're trying to do here. And that's why the struggle is so big. Because it says, once I recognize you, now I have to do something. I have to diagnose you. I have to treat you. I have to be able to provide you with that comprehensive kind of a care. And that's not easy, as you say. So I think we're in a very different time now. So I'm just delighted that, again, we're having those conversations, like what is included? And maybe the question isn't what diseases are included, it's what services are included. How are we actually going to take care of people? I'd rather we define a smaller number and really take care well than to say, okay, all of these are rare diseases, but guess what? We're doing nothing.
Gracias, Durgen. Y si la información viene...
And if the information comes with responsibilities, of course. And to close the panel, because we don't have enough time, I would like all of you contribute from your experience and from your ideas. What are the next steps within this context, of this global context that opened the United Nations for the resolution? Next steps at a global level from the perspective of Durhan, and a regional and local level on the platform that we have from Chad, and the local level, and all the countries represented here. Durhan, would you like to start telling what would be the next global steps, apart from the feedback that the UN needs to start and reaffirm the resolution as you tell?
That is, in fact, a very important thing, but I think it's the things you're going to be doing right in order to get there that is so very important. I will say is that, I've had many opportunities to engage with different patient organizations, other medical organizations, went down, had the great opportunity to be in Puerto Alegre when they opened up the Casas de Raras, and was just blown away by what is taking place there, and also visiting here. I think what you're doing here is absolutely the most important thing. And what we need to do at a more global level is to pay more attention, to learn from what you're putting forth here. But then you have an obligation then to get that information out there. You need to publish more. You need to hold these webinars and these conferences with more international audiences. You need to put yourselves into our space as well, so that we have to pay attention. Because I think not everybody knows the kinds of things that are taking place and the kinds of bottom-up innovations that are taking place. So I think on both sides, we can learn a great deal, and we can work really well together. So we're kind of looking at what you're doing. So.
Sí, bueno.
Well, and from AHF, I received the call from Durhan to generate data, to generate publications that should be specific to the context and the region that we have been working on during these years. And I make a call, because this is an opportunity for international organizations to go further, and apart from providing recommendations, see what are the opportunities to support their implementation, right? So, in Latin American countries and at a global level as well. But provide the guidelines and also provide support for the implementation of these guidelines. Well, in Colombia, and let's say we have a place full of Colombians mostly, and we have discussion related to our health system. And the first step locally is to preserve what we have obtained during many years, especially rare diseases. We have a constitutional principle that is related to not lose the process but progress on the right. And about that, with many difficulties, we have achieved, and it is sometimes strange, but we have achieved a level of coverage more important than some other countries in the region. A package with benefits for technologies that is better than other countries in the region, and without any doubt, a level of protection and finance that is higher than some other countries in the region. And it cannot be lost. That is a local discussion which should be consolidated in the framework of the debate that we have in this moment that is open. And this, of course, it is part of our regional context and Andean and Caribbean and Latin American context that Colombia can contribute with the same experience, and we can learn from we are doing in many other countries to consolidate these local efforts. And I would bet this from the point of view, the strategic point of view of public policies to social groups. So we will have that look in this local context that is current for us and for Colombia to be and continue to be the influence in this regard at a regional level. Well, I consider that the most important thing at a local level is strengthening public policies that we were able to create to continue in time and of course improve. But online, what he was saying, when you have regulation and their strategic lines are strengthened, and it's difficult that government changes impact in a negative way. So for that reason, I can say that many or the few achievements in the countries in the region should be consolidated, and I think it is fundamental to share experiences, success experiences, and our countries have different health systems that are totally different, and Argentinian one is particular, but I consider that there are certain strategic lines, let's say, that Argentina implemented that could be shared with the countries in the region, like the recent paid by result agreement for the first genic therapy in the country, or so other success experiences with amoeba for cystic fibrosis, and some other lines that first of all should be strengthened to stay in time. It's not a subjective or from a government or an ideology situation or the rare diseases, and that's what we have to fight for. And from there, we should join that. And after that, sharing success experiences in our region makes us richer, and Latin America with effects and virtues is going to cover certain matters that or certain situations that if we compare with the economic situation in a country in Europe, we don't understand how are we boarding that. However, it is real, and we have to take charge of that. Uh, we are not countries compared, not even with the United States or Europe or North America, but they have their strategy, and we have to use the strategies adapted to Latin America. The responsibility is from every one of us. So otherwise, we're not going to move forward. Well, I agree with my colleagues, and I think that we have different countries with policies, systems, different ideals, different governments that we have common problems, common issues.
And resolutions like this ones, like from the United Nations, are fantastic because they give us the perspective that we have to think jointly and take advantage of other countries' experiences. Not only positive experiences, also negative experiences, because for that, I think that we should have common initiatives that were here. It was good to integrate all the countries and different stakeholders and ask for the government's transparency on relationships. That is something fundamental. Scientific journals that would show strategies, positive, that are negative or positive. That are those are materials that should be shared between countries and among all of us. And what you can say that many times there is a difficulty of access. There is a difficulty to publish and to show all of this. That is why it is fundamental to take the next step, and according to that resolution, and have a better integration and transparency. So we all, as we say in Brazil, I don't know if it is said, reinvent the wheel, right? That is, we don't need that. So that is a great opportunity to take. Sure. Thank you very much to everyone, the panelists, and well, we will start briefly the next panel about the regional integration on excellence centers. Thank you very much to everyone.
Bueno, retornamos.
Okay, we are back now. As I told you before, we are going to analyze a success case in Brazil about an excellence center for the comprehensive and differential attention for rare diseases. And for that, I would like to introduce you to Dr. Roberto Giuliani, co-president of Casa dos Raros, or House of the Rares, and related to his new entrepreneurship and how to perform or how to complete it. Thank you very much for your invitation for this third Congress of Rare Diseases. I am always glad to be here and be in Colombia and being part of this wonderful group with many people involved in these topics. In my case, I need to talk about the situations and then Tony Darba is going to present in sequence. So I am from the Federal de Rio Grande de Puerto del Sur and Casa Genómica and also Casa dos Raros. That's a Genómica. Well, this is what I'm going to show you what I do. Okay, in Brazil we have at least 10% of the GDP. It's dedicated to health. It's not that bad, and it is aligned with many other countries and also it is aligned with Chile, with Latin America, a little bit more than Mexico, and to offer the situation. Well, the problem is when we analyze it from other side, uh, invest per capita investment compared with the OCDE that are the developed countries, which is the third of the country, and the rest of them is the medium OECD, and it is per capita situation, but it is a little bit more than in Colombia, and also the critical situation here is that in Brazil we have the public health system that covers all the population, and there is a quarter of the population that it is described for a private health system. When we analyze the coverage of the health system is 77%, and the private coverage is 23%. And when you analyze the resources that are applied to each area and the private insurances that have a 54% of investment in health, so that is a little bit unequal because it covers 77% of the population, and they only have this part of the investment. So we're going to talk about how it is the situation related to rare diseases. Up to not that long, the service related to rare diseases was taking place in the situation. There was no payment related to um, the genetics, metabolism. The few tests were covered, like karyotype, screening test, and data errors, and the visits for genetics were available in only few centers around the country, mainly in the southeast and the south regions. And the centers offer karyotype available and molecular genetics and some laboratories for reference. And it is like to pay this situation. Well, so the alternative we had from the very beginning was to have the genetic service in the university hospitals, like the financiation came from the budget for the education and research. So we started with the clinic hospitals in Porto Alegre in the south of Brazil, in which we have this reference center on rare genetic diseases. This is a center that has an important um, attention, 480 consultations or visits for outpatient visits and hospitalized patients. And it is a complete service that is part of a training and that we start with the LAG that many of you are aware or know about that, the MPS Symposium, the advanced course in diagnosis and treatment. And the, this course is performed with Carolina in the ICC and lysosomal diseases. And also we started with some information services. CHAT for teratogenic agents, the CM for service errors and metabolisms, SINISO for potential clusters of genetic diseases, and Hello Genetics information service for genetics for primary healthcare professional. It can be used in a case that could be a genetic disease, and they can call this service. And I'm going to talk about this number, about this service that there is a number, it is free. They have WhatsApp, they have a website. So that is something that is being checked in the service to the area of genetics or community genetics. And we have the diagnostics networks. That is the neurogenetics network, familial cancer, microdeletion, and lysosomal. Or we have one that is really well known is mucopolysa caridosa, and I'm going to give this example. Um, and we started when we started a job in Brazil for intervention to more than 100 families with children with mucopolysaccharidosis, and from birth until diagnosis. And there was an important number of visits um, and hospitalization, surgery, and the diagnosis took an average 45 years, 4.8 years on average. So we decided to do something, and what we decided to do was to complete this network to make easy the diagnosis and make easy the access to treatment. And we have a service with a free number, a WhatsApp number, the website, and the person can call. And physicians and the service have a base in Porto Alegre, but it has a network of services associated. So in the base, we make all the tests for this mycopolydrosis, and we offer samples. And this is something that it starts with that goes to the doctor to the doctor can collect samples and can send them to the laboratories. They arrive to our laboratories. They arrive to there, and then the report goes to the doctor. So this is without any cost because we receive financiation and donation from research agencies and also private agencies, and we keep this service in Brazil. And that is something that um, it is good. We started with this. Well, after starting the service and the average of MPS that were diagnosed in our laboratory, there's a laboratory where 4 cases every month, and after the presentation of these services, we passed from 7, almost 8, at least double. And these are patients that were they already existed, they were created there, and it was necessary to improve diagnosis. And about that, the system of more than 2,000 patients and have this, there is 1,600 cases, but they have different types of MPS. So this is what we are offering as international service, and you can see there is some kind of regional integration. Those are in red are countries like Chile, Mexico, Colombia, Peru, Bolivia, Nicaragua, Cuba, Uruguay, Ecuador, Guatemala, Panama. countries that already use this service, and that is something that works. And we identified also some isolated cases with an important number of certain diseases that can be an opportunity to say and identify some more cases. We have a community genetics, and the community is well known in Bahia, in Montefeltro, then MPS type 6, and it all started in the genetic area, looking for a collaboration with Bahia University in the region. So that is published. That was published a few years ago in the Journal for Rare Diseases. So happily, things started to change in 2014. It was not mentioned here. Well, it was mentioned here. There is a resolution from the Ministry of Health creating a policy of comprehensive attention for population with rare diseases within the public system, public health system, and rare diseases like 6.5 cases every 10,000. Two main axes: the rare disease, non-genetic rare diseases, and not genetic and not genetic diseases. And then on genetic rare diseases, we have congenital anomalies, intellectual disability, inborn errors of metabolism. So that was the work from the participation of the society together with members of the patients associations, patients, professionals in health, politicians and companies to get to this result. So it took us a little time. So from the year 2016, they started to designate these reference services for rare diseases, and we have 21 services that work for Brazil. 200 for 13 million of inhabitants. Those are the ones that are stated there, and they are on the east and more to the southeast center. It is more to the center, and for other regions, the services are unequal. Some others are complete, some others are not that complete, and it means is to have a reference system on rare diseases. It includes something, um, financiation to keep a multidisciplinary team and cover cost on patient medical attention, research, genetic counseling, and that is something positive in this moment. It is a little bit. It's not the same in financiation. It could be something positive. The
It's something that is positive, but that won't solve the problem. Just in my state, the last state at the bottom, we have 11 million inhabitants, and we have a waiting list for the reference consultation system of 3,000 people. That is a couple of years. We have to do something different to improve that situation. I'm going to talk about two initiatives. One is a network that is led by Dennis Felix. It is called Raras, the National Network for RDs in Brazil. It includes reference services, included neonatal screening, and it's trying to integrate that network to create a national registry of information on rare diseases, that information on access, diagnosis, and treatment, how this situation is in Brazil, and to create a map for diagnosis and therapeutic options that we have, and the available human resources in Brazil. They want to create an atlas for rare diseases in Brazil and to create an estimation of the costs of the treatment for RDs. It is a very ambitious process. And the other initiative that I am working on, which is the Casa dos Raros. We are opening the first facility in Porto Alegre. It is a new project with sustainable architecture. We inaugurated in February 28th on our Rare Disease International Day. It is ready to provide interdisciplinary care for clinic screening, diagnosis, and also to provide training. The medical doctor is here with me. She is Dr. Carolina Fischinger. It's 2,000 square meters totally dedicated to rare diseases, and this is the first of a series that we want to open. One is being planned in Sao Paulo. It's going to be much bigger. It's going to be a rare disease hospital. Here we have the first drawings. We already have the lot. And right now we are going to find the resources to build it. And then we have the intention of have in each region of Brazil, Brazil has 5 regions, to have at least one Casa dos Raros in each region. Unfortunately, Tony Dyer couldn't be with us in person, but he's going to speak through Zoom.
Gracias, doctor Giuliani. Y ahora tenemos online a Tony Daher, como bien...
Now we have Tony Daher. He is the president of Casa dos Raros, member of Raras.
El señor Daher está online y nos va a contar un poquito de...
Mr. Daher is online and he will speak from Sao Paulo.
Hola Tony, ¿cómo estás?
Conseguir falar com todos vocês. Eu lamento muito não estar presente nesse momento. Infelizmente, tive uma ocorrência aqui familiar que não permitiu a minha presença com vocês, mas estou acompanhando também online todas as mesas. Tão importante essas discussões para a disseminação, né, das doenças raras.
All of these discussions are important to disseminate information about rare diseases not only in our region in Latin America but also around the world. We have a common interest, and I thank my dear Professor Roberto. Thanks to him, we are improving the conditions with our patients in Brazil, and we are able to push our project forward that is very important for the region and for the world. And I'm going to talk about Casa dos Raros for this project. Casa dos Raros started as an innovation and engagement partnership. For those of you who do not know me, I am a father of a patient of Hunter syndrome. I have a master's in policy making. I'm founder of Casa Hunter, co-founder of Casa dos Raros, and president of the Federation of Patients with RDs. Roberto Giuliani, I think that most of you know him very well, but it's also good to recall that he is one of the most famous geneticists in our country and in the region. He founded the Institute for Genetics for All and also the Casa dos Raros. He's also a founding member of the genetics service in the clinics of Porto Alegre. He is member of the Brazilian Academy of Language. He is a friend and he started with this idea of Casa dos Raros. To be able to provide a further pillar in this ecosystem that is being built in Brazil for RDs. This is the path that we covered over the last few years. What we did is, it's clear for all of us that we need to build and have a structure that allows us to have a solid basis. That is why we work hard to disseminate the knowledge and work on awareness and place the patient at the center of our efforts, create awareness among the community and the families, engage with the families and train our doctors. As you know, most doctors do not know about rare diseases, so we need to work on training and continue to work with them. We also annually we have several events, among them 2 important events. Last year we had several Latin American associations that participated in an annual event where we brought together our stakeholders, the government, deputies, congressmen, secretaries of health, associations of patients, and doctors. Everybody that is involved in RDs. To understand where we are now and what we can do for the upcoming years. We also have campaigns for several types of RDs. We put forward at least 15 campaigns a year to create awareness about these RDs, and one of the services that we created since 2014, and it's very important, is that we created a project called Tain Hunter that right now provides 4 services in 4 Brazilian cities, and also the Casa dos Raros that is going to provide the service as well. We have an interdisciplinary team of doctors where we care for the patient once a week for the patient and the family. So instead of a patient being in line and waiting for months or years to access to this interdisciplinary team, he has access for one day to this interdisciplinary team, especially the mother that comes in much more ill, much more tired than the patient itself, and we have a team of psychologists to provide care, to provide guidance, and to provide a proper care plan so that he can take care of his child or child. This is important that, yes, this is the day hunter model where we save time for the patient. He gets better attention and he gets a quick diagnosis and also a very structured care plan for this that is tailored to this patient. And we cannot forget about the thousands of projects that we have. I only have 4 of them on screen that are very important. But to work on the ecosystem, we first have to look out regulation in the country. And when I talk about access, I'm talking about diagnosis, a prepared team. And then if we have medication, that's also a good thing. And for this, I need to have regulation that allows us to do R&D and on drugs and treatments. This is why we heard with COEPIA, PISA, to have these resolutions that will allow a fast track for registering medication and to approve research. Casa Hunter was very important on this. I would like to applaud the presence of Dr. Mendes. He is a great person that has a very important position at MBISA and was also very keen to study RDs, and also colleagues. They are colleagues because they are really the ones that had the awareness to understand the importance of RDs. They were very important in medical innovation in our country. One is the general director at Porto, who is Dr. Mendes. He has been celebrated by us because they are very sensitive people, and they created a very good environment within the agency to be able to enact this resolution and change the way we do approvals in our country. Thanks to this change in regulation over the past 10 years, especially since 2017, today we can consider Brazil as being very close to the first world in this aspect. Also, 2 years ago, we approved at the National Congress, that is why our public policy work is so important. We approved a bill that approved treatment for 6 RDs, and we approved projects that moved that number from 6 to 50 RDs, and it will be implemented over the next 4 years. And this is key for us to be able to talk about access. We can't talk about access without a diagnosis. This is why we have worked very hard over the last 10 years to create a favorable regulatory environment, and right now we are working on public policy to have a favorable environment for access to healthcare. This is why Casa dos Raros project, which is very important for the country because all of these projects, all of this diagnosis, but without having an adequate center that really solves the issue and provides dignified care for the patient, it will be all for naught. Why do I say this? Well, there is a study. Dr. Roberto and his team reached a conclusion, and Dr. Roberto has a genetic center. He said that the patient can have early symptoms up until and have a proper diagnosis and have a proper management plan. It will take around 10 years. This is not right, so I can happily tell you now that we have these reference centers. I apologize for all of the doctors that are part of this center, but how will I consider it a reference center if it allows within the single payer system that a patient dies waiting for a consultation? You all know that 30% of patients of genetic RDs die before 5 years of age. And unfortunately, they die waiting in line for their first consultation. Majority of our states have a queue of more than 2,000 patients, 2 or 3 years of waiting for the first consultation with a genetics doctor. Then it takes a few more years for the tests. You know that these are multisystemic diseases. They attack the system as a whole, so they need an interdisciplinary team of doctors to take care of them. So unfortunately, the patient does not have access on time, and walking back, this is impossible. When we reach a diagnosis, unfortunately, they do not have enough time to get treatment. And this is what we want to change in our country and around the world, because the model that we've created is not just to build buildings and centers. We created a model that shortens the time from diagnosis to management plan and to provide a dignified care for these patients that most need us. The idea behind creating Casa dos Raros is to create an ecosystem for RDs in Brazil to reduce the time for the journey of the patient from the early symptoms up until diagnosis. Then getting an interdisciplinary diagnosis, and also to promote public policy to accelerate access to care, and also to fund research and bring training and continued education for all of our professions. So Casa dos Raros is promoting all of this. So what are the services that we will have at the first Casa dos Raros? It has already been inaugurated last month. We have already 2,000 patients signed up. They signed up to be cared for. This proves the need for these centers. So we will provide a service through a multidisciplinary team to attend to the patient and their caretakers, because we need to take care of the caregivers. We have several laboratories to do the necessary tests. We provide specialized training for the whole medical team and non-medical team. We also are going to have clinical research and innovation in technologies. We will have genetic counseling. And we will have a biobank registry and to collect data. This is very important. I think that it is very important for all RDs. We are in an alliance with the municipal governments and local hospitals, because we are going to serve 60% of the public and 40% of it is going to be private citizens. So that's why we have alliances with public and private hospitals, with the government, also with two main federal universities, the Instituto Caldera and the University of Pennsylvania. And we are also part of a network called the undiagnosed disease that are a challenge for all of us. We are part of the only center in Latin America that is part of it to be able to provide diagnosis for undiagnosed disease. We have an alliance with Barça Genómica, which is the biggest diagnosis lab in our country. There are more than 80 branches in our country to improve diagnosis for these patients. Aside from this, we have a big project for Brazil and also for outside of Brazil. One of the projects, I won't discuss them all, will be the second project of the Casa dos Santos, which will be the Dos Raros Hospital in Sao Paulo. We will have a care and research center, and we will also provide surgery. It will be a complete hospital. That will be the first hospital in the world. There's no specific hospital in the world for specializing in RDs. It'll be the first. We already have the lot bought near other interesting healthcare providers. And right now we are working on making the hospital a reality. As you see on screen, we have research, advanced research, genetic therapy, and also education and training, because training our human resource is a big challenge in terms of R&Ds. We need to continue to push this message to our doctors, so that in 10 years, a person that works in healthcare has to understand something about genetics. Otherwise, they are going to have difficulties. Innovation in health is being built upon the work derived from RDs. The basis for this was DNA, genetic therapy. everything was built upon the work being done for RDs. The Dos Raros Hospital is just an innovative model that is anticipating the future, but it is also showing us the pathway forward in other diseases, because in the future we won't have bigger hospitals in 10 or 15 years. We won't have huge hospitals that attend to every patient. We are going to have smaller specialized hospitals for specialized diseases. They're going to do very precise diagnosing, and they're going to be more efficient in treatment. It is going to be called focus therapies. The Casa dos Raros provides a view of this future, but for undiagnosed diseases, because I still feel that these are diseases that are not being treated, while Brazilian patients and patients around the world are dying waiting for the doctor. We need to reject this. This is a crime that is happening indirectly, and here at Casa dos Raros, we will change it and we will create a sustainable model within the unified healthcare system. Before I conclude, I will play a video that shows Casa dos Raros in Porto Alegre. Quickly show you what happened during the inauguration. And a testimony from Adurgeni. I hope that in Colombia, I can work with Dr. Zarate. Hopefully we will have a Casa dos Raros in Colombia.
shining examples of not only support for rare disease patients and families and a standard of care, but I think it's so important because it's been built up from the ground, from patients and families who are very much themselves affected, but also wanting to actually provide a space for others. I will say frankly, and I travel around the world, I do not know any other place that is like this. This will be a model for what can happen when you bring together people that are not only visionaries, but also people that can attract others from the clinical, from the research, from the philanthropic communities to actually create a space that is designed specifically for patients and families with rare diseases. We are so very, very grateful to be a part of this, and we're looking forward to how we can help not only expand it, but to learn from it and to share it with the rest of the world.
Bueno, muchas gracias.
Thank you very much, Tony, for your presentation, and we are here supporting you from Sao Paulo. We are all integrated in a single virtual network, so welcome to this conference from Sao Paulo. And great initiative, grand entrepreneurship. That is great to know. Well, the question would be, how are we integrating this? There is an initiative to replicate Casa dos Raros in Colombia, so I would like to know how the entrepreneurship that you have considered here. Well, after analyzing this, you feel really happy and thrilled with this work. I would like to tell you about the story in Colombia. Colombia has a law related to rare diseases in 2010 and has three pillars. One is making a surveillance system, and we have completed that and managed costs and centralized um, purchase system. And the third element was to make a reference center um, for patients with rare diseases. And the law that I started with that made a reference split it in three: diagnosis, treatment, and pharmacy. But the law was not regulated in there. Just up to the year 2018, the law was regulated. In Colombia, it is a resolution, and that resolution said how where how the reference centers should be in Colombia, but the conditions of that resolution were really high quality, 23 criteria that an institution should comply with to be enabled as a reference center for orphan diseases. And that is for each disease. If we've had 2,236, there should be 2,236 institution enabled or one including many diseases. After the resolution in 2018, so far there are 4 centers that we are aware of available in Colombia, and the others are pharmacy centers for multiple sclerosis. But they give us a competitive advantage in managing these medications for multiple sclerosis. As you can see, we have the most frequent disease in Colombia was useful for patients. However, we all question ourselves why treatment centers were not available here. Something similar to Casa dos Raros, and we started to work with that in Hospital San Ignacio, and there should be a board of directors interested, and Julio Cesar Castellanos, which is the head of that has, and he's clear that the genetics is going to change the world of medicine and pharmacology, and the hospital decided to start a reference center and starts working to making the preparation for this place. Just the document to present to the Secretary of Health is close to $5,000 just to prepare the document. But for a center to be enabled with the conditions of that resolution, should have all of the health services, surgery, intensive care, or emergency, physiotherapy, nursing, genetics, and few hospitals comply with that in Latin America. And maybe if we can analyze hospitals in Latin America, they can be counted with your fingers. But San Ignacio is committed with that. And we started the process to enable the place. We cannot enable a single disease. There are only few disciplinary teams in this group diseases, and make them in groups, take them in groups. We cannot, and the resolution allows us to make alliances with other strategic allies. We know some other hospitals as Cardio Infantil Foundation and La Misericordia, with which we should make alliances. And this is the model we want to follow, that the patient should go once and can be received or can have a visit with all the specialists, and the specialists make a decision to manage that during a long time, proposing management through by years, classifying the patients according to their risks to offer the best attention possible. It doesn't mean that patients should have a visit here in San Ignacio, but the management plan should be performed right next to their houses. Pandemic shows that we can go to the patient's house to help them take the medicines to their house. Consultations through or visits through telemedicine, and with these pathologies, we will have the experts group assisting the patient close to their house using telemedicine. Physicians around the city. The specialists would be there treating physicians, but for a plan that is coming from the reference center. What is the phase? We are developing the documents. We hoped up to May and half of the year we would be able to present to the Secretary of Health the first preparation of this document. The Secretaries of Health do not know how to enable the reference center, so we are going to learn how to do it.
And when we started with this initiative and when we met with Roberto and Tony, we can see that the same model can be applied here. We can take it to other places in the region. If they were able to do it in Porto Alegre, we can move forward to that. And it should be a knowledge network to meet our patients. And when we have these reference centers where we have the cohorts of all the patients, we can start a research in all of the diseases and find out about the natural history of the disease. Sometimes we don't know what is happening, and can apply clinical protocols arriving from the pharmaceutical industry or in our countries. In Brazil has been an example that we can make a genetic therapy in-house. So that is the commitment that we have, and the idea is that we all can not only start with the center in San Ignacio, but support centers in formation in here in Colombia, in other countries, and being like, I don't know, like franchise of Casa Los Raros, and we can find the name to sound good in Spanish. But of course, we will be able to start with that and make it a reality. That is everyone's dream here. Of course, thinking that I don't have to go to, let's say, taking the 10 steps in Bogota for a patient to be assisted with receive attention has to go to 5 different specialists. Everyone is in a different place. They don't speak among each other or within each other, and so one takes the treatment from the other with the best criteria, of course, with the best intention. But we cannot manage patients like that with orphan diseases, and we hope to give you good news soon. Fantastic. Well, and also call to all the ecosystem that this is a replicable model in the region. So we are all here together to generate joint projects, and this could be one to replicate in the region. And I would like to thank Dr. Giuliani and Dr. Sarante and Tony to share this great initiative that is being developed, and we hope that it can be replicated soon. Thank you very much for being with us, and we'll continue here having our conversation.
Bueno, volvemos.
So we're back. Those that are here, we are back. And those that are outside, let's start over again. We have testimonies of patients. We have testimonies from patients at a regional level. And we are here with Mariana Moriano Acevedo, with which we are going to talk a little bit about watching this video from patients and caregivers at a regional level. I hope that we will receive some education about it to understand the situation the undergoing situation.
Otro más necesitamos.
Hola, ¿qué tal? Mi nombre es Jenny.
Hello, my name is Jennifer McDonald. I am in Mexico City and I'm here because I'm an Alpha 1 and I'm happy to be here. My name is Lina Silver. I'm from Ecuador. I'm a patient of Turner syndrome for about 12 years from the Ecuadorian. Hello, I'm Julissa Cruz. I am the mother of Martina Actis. We are from the Dominican Republic, and Martina, she's 5 years old, and she's got the Saga disease. My diagnosis is deficiency in alpha 1 antitrypsin, which is antitrypsin, and that is rare. More the rarest in Mexico. I was diagnosed in 2014, and I was re-diagnosed in 2015. It has been a complicated process, a complex process, to obtain my medicine, my vaccines, and from that year I've been diagnosed. Since Turner syndrome is a genetic infection, I was born with the syndrome, and when I was 12 years old, I was already aware of my diagnosis, and endocrinologist told me about that, but the treatment was not it was not given on time. That was not the right one. When I was 14 years old, the endocrinologist Raul Hervis, he was able to give me a diagnosis and the proper treatment. My daughter Martina was born in a regular way, in a normal way, a full-term pregnancy where skin. So that could be something related to the position, and there was a normal development up to 6 months. When she became 6 months, when it is the moment in which children reach certain milestones, Martina didn't reach those milestones, and we started seeking for the solution. And we went to MRIs in whole exoma, and 3 months later. After having that moment, up to 11 months to the exome, we received the Salas disease diagnosis. So there were many fears. Mind play with different situations with you, many moments of depression, anxiety, being alone, feeling loneliness, and we are afraid. The fear that I have more is that my disease can cause me a disability, a difficult disability that I won't be able to be independent, that I have to depend from someone to do the regular things you do. Not knowing and facing the unknown generated a lot of pain and difficulties and everything that was related to that result that we didn't know. What about the treatment? So there was a diagnosis. If there was a diagnosis and the proper moment together with the monitoring, I wouldn't have this. This year is my 4th year with a treatment, and I can tell that it is not only on the skin, on the hair, and the way to breathe, and the way I can speak without fatigue, without having this difficulty
to breathe without using the BPAP. There are moments during the day that are really, really, really bad, and still they are really bad even with the medicine, but they are minimum. However, having the treatment, the proper treatment, avoid me to end up having a severe osteoporosis. That can happen if we don't have our hormone treatment. The problem that it generated me is not that it was not detected on time, because for girls there should be the growing hormone, but in my case, since it was detected during um, my adolescence, wasn't able to access to the treatment. The difference here is a big difference, but in terms of development, our girl needed to receive therapy from the zero moment, and it is that way that we didn't expect that diagnosis, so she would be able to receive the physical therapy, occupational therapy in the future, and speech therapy, because unfortunately the disease does not have any type of experimental treatment, and in that moment it was not being under this research. Now we achieved that Martina was able to be the first patient to open a protocol for investigation for the Salas disease in the national institutes in the United States, specifically in the Institute of the Human Genome. I can tell that the access to treatment that has been another odyssey. Um, as you know, it is difficult. It was really difficult because the treatments are specifically expensive. In my country, the medical situation is complicated. The public sector is very difficult to find. Up to 5, 7 months is not the treatment is not offered in hospitals, in public hospitals. There is no access to the medicine that we need. Now, unfortunately, in the Dominican Republic does not have any registry system to include patients with rare diseases. We don't know who they are. We don't know where they are located. We don't know what they are suffering from. We don't know what are their specific needs. And as long as these associations in patients, ADAPA, the associations, the Alliance of Dominican Alliance for complex and rare illnesses or diseases perform activities together, we will be able to achieve many things. Financing. So we're not having the medicine. I went to a coma. I was 15 days in a coma, 5 weeks during intensive therapy for not using the medicine. And the part from the Ministry of Government, the Ministry of Health of the public health system does not give me the medicine to that moment. I wasn't receiving this moment. After having the legal process, I was granted with all with the medicines, and that's why I get them. So thanks to the Mexican public health system, after having a long system and heavy system, I was able to have them, and I have them week by week. In Ecuador lately, up starting November last year, there was a single registry of rare diseases patients. Unfortunately, there is a process that is very slow, but we as social organizations are supporting and registering our patients, and having this registry is something fundamental to demand and comply with our rights. Then we have our medicine and prioritize attention. And in the case of my daughter Martina, she was born including an insurance, private um, medical insurance, but that with certain characteristics that allow her to receive all the therapies. Advice. Regarding the second opinion, go to get the second opinion of a physician. That there shouldn't be that there is a change in your way of thinking. Go to genetist, change the physician, and do not lose your time. Patients, I would recommend that we should have a lot of faith. That always we should be optimistic, mostly that the hope won't die, and that God gave us some difficulties, but we also have the strength and wisdom to continue
working with this, and the parents that are in charge of any girl or boy, same thing, and living here and now. Um, give all the care and love possible because love heals and extend lives. Welcome, Mariana, with us. First of all, I would like to, on behalf of all the organizers, to um, have a public apology for all the people here in the auditorium with mobility or difficulties because we had um, difficulties to find out ramps, and I would like to outstand this because it's one of the barriers we can find in the organization and from the variables that we have had in the organization. That was one that was not able to overcome. And I want to show to talk about this because we talk about big scale related to access barriers, diagnosis, financing. But I think that these barriers that you live every day, you find it every day. Also, I wanted to talk about and open this conversation with you, asking for apologizing with you and for all the rest of the people that are here, and well, give you the floor and start talking about your experience. What do you think about what we are discussing now? Well, in the first moment, first of all, for inviting me. Well, and I want you to think and that physical barrier is not only some stairs, some steps, and not putting a ramp. Is the reason why organizations and patients are led by caregivers and not by patients. That is why we as patients decided to not come, decide not to participate, and these spaces are led by other people, and our voice is not heard. The patient's voice is as important as a caregiver, as a doctor, as the industry, as such. So that reflection is really important. Sometimes we don't go out home from home because it's difficult to live with a disability, but our environment is not adapted. It is the one that makes us disabled, and a person is disabled because they have a person. This person has a physical condition that cannot be that can allow that doesn't allow this person to develop as other people. That is what is more important for me. It's not the fact that we take you up or take you down. Is to think about what we are doing and as physicians, as an organization for patients. Because what if there are organizations without patients? They wouldn't exist. So I am talking about that. That is a reflection I would like to give to all of you. Well, thank you very much. Thank you. Well, now we can talking about your story. Can you tell us a little bit about how was your diagnosis? Your how does it? Well, that was not easy exactly. I was born in 2002. I'm 22, 21 years old, and during that time, well, there was not too many things known about rare diseases. Even now, you don't know many things about it. It is a small niche of those doctors or those physicians that know about it. I started having symptoms 1 year after delivery. I didn't have. I started walking a bad way, and due to many reasons, I have an aunt that is a physician, and she said that is something neuronal. We don't know what it is. After visiting many physicians, I had a biopsy on a muscle and electromyography, and in there it shows that there was a possible muscular atrophy. So it was not conclusive. We didn't know what was happening, and
I talked about this with a lot of I'm really clear about this that I was a girl and I didn't know what happened, and I started living the disability later in my life. And this odyssey uh, wa- was was my mom, the one who lived this odyssey. And after about 10 years later, I have my first genetic diagnosis that confirms my disease. I had to, well, I walked, I stopped walking, then I had two surgeries, and no person was aware of what was my situation, of my condition. So it replicates to many of the cases that we have heard so far. Um, the time between the first symptoms and official diagnosis. Well, can you tell us about your treatment? How did you, or how were you able to find treatment? Currently, I don't have any treatment. In Colombia, there is a single treatment that is available for patients. However, I'm not part of those patients that can access to the treatment, and that is something really important: access to treatment, access to physicians with the knowledge of that. But even I was able to have the chance, unfortunately, to get to specialists that did not know what was my illness and my disease and my clinical um, history. They have a genetical test that offer a real thing. When we talk about treatment, it is wide. It is not a medicine. For me, my treatment has been therapies, access to physicians, to I didn't have any and up to 15, 16 years old, and I went to medical boards, and I didn't want to have any treatment because it sometimes happens because I didn't know what to do. However, it happened because I have a sister, and she's 6 years old. And since the moment she was diagnosed, and she received a comprehensive treatment, and it started from knowledge and the path we have walked through that I was able to access to a comprehensive treatment. So no, I didn't have any treatment up to after passing my childhood. I think it is important about the intervention from Mariana today because it allows us to give us a perspective and take down what means to have all these challenges for the treatment, diagnosis, and day-by-day situation people live every day. But for us, that we are here today talking about the situation, these are problems and difficulties they face every single day. So I think that this space and this intervention you are giving here, Mariana, is really important. Thank you very much for your, well, to be here and sharing your story. I don't know if there is any other thing that you would like to say.
Una.
Yes, I would like to add two things. One is that access to treatment and a specialist is very important. In RDs, due to time for us is precious. Time for us means that if I start my treatment while still being able to walk, maybe I can keep my ability to walk. If I start my treatment late, it would be a different outcome. Time for us is precious, and the second thing that I would like to add is that we are not only patients, we are also people with projects, hopes, and dreams that we need to fit our lives around our disease, and unfortunately, we have to do it. I've always said that my decisions in life shouldn't consider my disease as a limiting factor, but it ends up being one anyway. So we need to find new ways to live while being disabled and being able to overcome physical barriers and emotional barriers. We need to be able to overcome them, and if we have access to treatment and specialists, this will provide for a better quality of life. Thank you, Mariana, for being with us here today. Thank you, Mariana, for your courage, for your honesty, and for providing us with some important reflections. Now we move into an holistic view, mini break, and then we move on to our last panel, or one of the last panels.
Dimensión holística de la educación y capacitación del personal de la salud en enfermedades raras. Ese es nuestro próximo panel. Y me gustaría invitar a nuestros 4 panelistas y expertos, a la doctora Alejandra Vázquez, directora del Departamento Académico Ciclo de Vida de la Facultad de Medicina de la Universidad Autónoma de Guadalajara, en México. A la doctora Marta Tamayo, directora de la Fundación Derecho a la Desventaja y docente del Instituto de Genética Humana de la Pontificia Universidad Javeriana, que nos hospeda. A la doctora Olga Echeverry, profesora asociada del Instituto de Errores Innatos del Metabolismo, también de la Universidad Javeriana. Y al doctor Terán, con quien ya también tuvimos el placer de conversar, médico farmacólogo y presidente de la Academia de Ciencias de Ecuador.
To start, I would like to ask Dr. Tamayo, what are the gaps in training for all of our specialists in terms of RDs? I think that the most important things brings us to the title of this panel, which is a holistic view. That's the gap. Nobody knows what holistic is. Healthcare staff do not know what a holistic or comprehensive view is because we haven't taught it, nor we discuss it in medicine schools. I have been teaching this at Javeriana University for 40 years, not only because I'm a genetics patient, but because I really understand what we require. The School of Medicine, the health sciences do not understand what a holistic view is, nor what a comprehensive care is. I think that our healthcare professionals do not get training in undergraduate or postgraduate to be able to understand their patients that are a human being, but they're above all a human being, but look at the patient with an integral view. They get to a hospital and they say, no, that's not what I do. And yes, that is for you. That is something that all healthcare professionals need to understand. That is a big gap because this is where the holistic view comes in, which we do not have. Number 2, the academic programs in medical schools do not include anything on this topic. We are trying for it to be included. Number 3, professors. We do not have trained professors. So if the professor doesn't understand the issue because he was trained classically, then we cannot escape the vicious circle. I'd like to see all of my students here sitting down totally immersed in this new topic. All of our alumni are doing it. This has been the fruit of the labor of many years, but this should be done. We need to do it in undergraduate and postgraduate degrees. Why do we need to close this gap? Because the patient is the one that is affected, that has to go through the diagnostic odyssey that we saw. That is unforgivable. Thank you, Dr. Vázquez. What are the challenges that you see at Guadalajara, Mexico, and at the regional level? If we could talk about the regional challenges as well. As we saw the whole morning, challenges, there are plenty in many areas. Starting with the undergraduate programs, we do not have a course on rare diseases as such in any of our medical schools in Mexico. And looking through all medical schools in Latin America, there is not one either. We do have a genetics course, basics of genetics or molecular fundamentals or clinical molecular, but to see it in a comprehensive manner, look at it. RDs in a comprehensive manner does not exist. So that's the first challenge. And I could continue on, but at Universidad Autónoma de Guadalajara, we see them as areas of opportunity, and we start by looking at what we do have. And there's where we start to work. We have been implementing a program for 6 years that starts in a course being taught together with civil associations. So within this course, our objective is not only to provide basic skills, but that as healthcare professionals or also future professors or of future doctors, we want that through this project, bringing together associations and students to create a bond and trying to create awareness in these students of this comprehensive view of patients. So alumni from our university, which by the way, this program was created and is now graduating 1,000 doctors a year, that wants to deliver, that they have to deliver a final project, part of the grade, it's mandatory. They have to approach an association, many patient association, they interview a patient and they have to generate pedagogical material that through some sort of narrative, they are able to explain to a child with an RD something about their disease, because yes, we teach them about DNA and PCRs, but we do not move into looking at patients' needs. So this work that they do with civil associations is a experience for them to see firsthand what it means to create a connection with a patient. And based on this experience, they go through this project that has a grade. It's not optional, it's part of the curriculum. And we also do it as a contest. They have to turn in their project, but they have to go beyond, because the day they present the project, we invite judges that are not us professors, but it's the patient in these associations that go and evaluate these projects. It's been a very enriching experience, very fruitful, because we all win. The student is more aware of patients' needs and understands how to create the connection, and that's beneficial for them, and it's very beneficial for the patients as well. As I said, we have been replicating this program together with the Mexican Association for RDs. We've graduated around 1,000 students a year. Around 5,000 students have gone through this program. And we are trying to create an impact on the student for them to understand that they are going to be the future doctors. And this project is in their last semester. So the next step for these students is the clinical practice. Yeah, this is not something in first semester that by the time they graduate, they don't even remember it. Yes, we want to highlight that being a first point of contact doctor is very important. This is something that all RD patients face, and their role in their treatment is going to be key. And then they start to refer patients to us, and everybody learns from everybody. I invite you, if you have direct contact with students, maybe we can replicate this program, and it could serve as a model for it to be replicated, and we get closer to society. Yes, you mentioned that we speak about gaps, but you told us about what we have been doing. So now I would like all of you to tell us a bit about the progress that's been made. Good afternoon. Dr. Vasquez gave us a great example of what has been achieved in medical training, but I want us to think about the training of the rest of healthcare professionals. I also work here at the university and have been doing so for a long time. I teach at the sciences school, basic sciences school, at the Institute for Rare Diseases. Maybe leaving aside our humility, I think that the sciences school at Javeriana is the only one that offers a course on genetic errors of the metabolism. Not rare diseases as such, but that leads us to have many healthcare professions like nutritionists, microbiologists, pharmaceutical chemistry. They can have access in undergraduate studies to understand about these diseases. And as we've heard throughout the day, this is an interdisciplinary effort. This can't be taken upon by one of the professions. It has to be an integral effort. So this is one of the accomplishments that I can mention, but I can also tell you that at our institute we have had 150 residents in geneticists, in neurology, pediatric neurology. This year we will start with residents in pediatrics and obviously in genetics. They work at our labs for around 1 or 2 months, where at least we plant the seed of knowledge about these diseases. Because as the doctor said, yes, we then start getting many calls from the students a year later telling us, I have this rare disease, please help me, what type of a test can we take? And we start to integrate the professions that should be the ideal. This should include other specialties as well. We should bring in pediatrics, we should pediatricians, we should bring in social workers, we should bring in many other specialties. But there's small steps that we've started to take over the past, in my case, 30 years. If we look at an event like today's, it is very gratifying for us, for those of us who started 30 years ago with just 4 students. Yes, we can make it, and initiatives like these are the ones that we need to try to scale up. Yes, I've been teaching for 25 years myself, and I have had the pleasure of being in obstetrician and medical technology fields. And this is a challenge that unfortunately is not easy to overcome, because the courses in the health sciences courses cannot be added to because we couldn't have thought that we needed to teach molecular biology, genetics, but we needed to include all of these new courses, and in this process, we lose space to be able to work on this holistic concept. And I would say that we could even call it a humanist approach. Because in the health sciences, we can make the mistake of prioritizing science over sensibility and awareness. And this is one of the elements that we shouldn't lose as a fundamental axis. At University of San Francisco, where I work, it is a liberal arts college, and we have a basic curriculum for all careers, for all majors. And in the case of medicine, there has been a major challenge because within those 6 years, we provide 2 additional years for the liberal arts, in which we try to give other skills to our students to be able to provide more visibility and adopt a holistic point of view, but it is still not enough because after training comes the realities, which is providing healthcare. In Ecuador, at least, a doctor has to see 40 patients a day, and he has only 15 to 20 minutes for each of them. So we say, how can in 15 minutes can a doctor establish an adequate interaction with the patient? He barely has time to read his name, his diagnosis, and prescribe medication. We need to understand that the fundamental axis is interaction. This relationship that we can establish, and that unfortunately we give less time in training, but we need to do more. Yes, this is a very interesting concept, Doctor. Thank you. I would just add that it is important to highlight something that has already been said. We need agreements between universities and patients' associations. Yes, everything about us with us is the saying, which is what the patients' associations say. We also need to jump into the general population approach. This is a societal problem. So we need that relationship, we need agreements where all of healthcare careers are in touch with society so that we can educate society as well. And this leads us to our next question. How can we bring in patients and patient associations and patients' families to participate in this training? Participate by giving their testimony or as part of the audience. I would like to say something. This is something that we've been doing from the school with a master class. We mentioned something about this in Guadalajara. What did we do? Many years ago, we said that within the curriculum, we need this style of education, where the students have access to first-hand knowledge and first-hand interaction with an RD patient. That class would be Inclusion, Medicine, and Disability. There's another very similar course, but we try to bring them together into one. Everything starts in the first semester of school. I have another course which is Communication in Medicine. because in my free time I started to study journalism, and so I'm also a journalist, so that's why they told me that I had to teach this. I think that first semester students need to be taught how to speak to a patient, how to communicate, how to be empathic, which is required for them to appreciate us and help us. They need to understand our situation, which is a lack of time that Dr. Teran mentioned. This is complemented with the other course because they not only do a course, you've seen how difficult it is to access this university because it's up in the mountain. So the students have to work on moving around in a wheelchair. Others have to live as if they were deaf or blind for a day or not understanding, or they need to be able to live what it means to be a patient. And then we sit them down asking them, how did you feel? How did you live it? And this is where we move into the inner brain and stamp him with this experience, and that will carry it, which we will carry throughout his career. And this is not only for doctors, this is cross-cutting exercise for lawyers, architects. The whole of the healthcare sciences come in, and this is one of the models that we also want to replicate. We do not need to we need to replicate it throughout Colombia and throughout Latin America. We've seen many things today that we can replicate. Let's copy what Guadalajara is doing. Let's copy what we are doing here. But it's not only for them to see, but they need to live through it, because going and talking with the patients is something. Yes, I know. I am also a patient. I've also sat across the desk, and I know what it means for a doctor not to speak clear. And I tell the doctor, not speak clearly because I do not understand. Sort of things we need to impose them, and this is part of our task. People with disabilities or rare diseases are the ones that know what we need. So we need to say it. We need to teach it to the healthcare area. So it's nothing about us without us. Ask us what you can learn a lot. And this is what we teach our students. Ask. You need to learn how to connect to that person, which is very important. And this is one of the things that we do at the university, but we can replicate it. Yes, we've talked about creating more awareness on RDs, and I would like to know how we can bring in specialists so that they get more training. We say that at the regional level we have very few geneticists, very few specialists. So not only creating a generalized awareness, but the expertise. How can we disseminate the urgence of more specialized doctors in these fields? I think that the best way to bring this knowledge to the medical field is by planting these seeds that we plant in our students. Through our lab, we see specialists and residents come through. That pediatric neurologist that is going to then work in Medellin or Cali, and he will find that he will work in an environment where he might encounter one of these patients, and he will say, well, what is this? But he's going to be the only doctor that has at one point had a course with Dr. Tamayo, and he knows that rare diseases exist. So he will start to create this need and tell his colleagues that we need to study about this. We need to talk about RDs, and so why don't we bring in an expert that can teach us about this disease or that disease or about that group of diseases, and that it will bring a snowball effect, and it will grow with time. And for this, we also need a network, like Dr. Vasquez said, a network of professors that are able to transmit their experience throughout these entities, and the snowball will grow more. For me, teaching and training and education is the key to everything. If we are able to reach through more doctors, we will be able to grow in all aspects, because somebody that learns the theory about a disease, or somebody that got to see a patient with one of these diseases, will start to ask questions and more questions. And obviously, he will start to come up with answers. He can create diagnosis, and now how can I treat them? So this is where the pharmaceutical company may come in to get the proper medication. I guess that this is the same for any rare disease.
So, that would be great, and it would be desirable to give that information to the postgraduate studies students. That would be the desirable thing. But let's see the reality. The best it would be best to make this mandatory in all the specialties and try to involve the decision makers in the education area. We have discussed about decision makers in health, but involving those that decide curriculums and try to make them part of the programs as something mandatory, since we offer them the need and desire or wish to, we could impact a little bit more instead of performing this program, making this program or preparing this program to replicate in all the specialties. We mentioned it at least 5 or 6. But tell me, what specialty would not is not related to any type of rare disease? All the specialties in the end will require the support of from a genetical service, since it was not included in the curriculum. I'm not going further. Let's say oncology, pain medicine, palliative care. Um, well, there are rare diseases that, for example, are present in geriatrics. Any of the specialties or the postgraduate courses should be impacted in this and should be included in this type of courses, right? Leaving them as a some kind of policy. I wanted to say that. I agree with that. I think it is important that it is part of the curriculum, not telling one to the other. It works like that. No, it shouldn't be like that. It should be part of a pensum. Within that time, we can go there and to medical congresses. Tomorrow, I'm not going to be here. I'm going to be in Cartagena teaching ophthalmologists, retinologists in all Latin America what is living blindness and how to manage everything. And that is what I do. I go to all the congresses and I give me 30 minutes, 15 minutes, and in the meantime, oh, I'll be there in the part which is in the meantime while it becomes mandatory. So, Dr. Teran, can it be regional apart from replicate the models, the successful models in each country? Can we make it regional? I think that is a challenge, an important challenge, because culture from each of the countries um, give in a certain way the behavior, but empathy is what should be the first. And about the level of professionals and health professionals we have there, um, an intermediate barrier that is reaching professionals in health. So It starts from the person that opens the door, the driver that cannot understand difficult things, um, up to, let's say, the same patient that with a difficulty to transmit or say what do they feel, what they have. Generating educational activities, it should be in environments that should be horizontal. Activities like this ones are challenging, of course, because we have to mediate the technical and scientific to be understandable for the public in general. So in general, we go to the one of the two ends. High specialty congresses that we talk about the last gene in which we and how to sequence them, and that is okay because we all feel realized about the progress, and then we cannot transmit that in a simple way. It is enough to tell a specialist on radio and television, and we all will be um, surprised to not understand anything like that. But at least we are related to it. Can you imagine the rest of the public? So it is important to find those mediation strategies. It is not lowering down the knowledge level and amplifying the complexity of the discussion, but achieve the sensitization that is general for everyone. And listening to strategies from different countries would generate models that would be different for the adoption or to take to get to a very performance. Well, thank you very much, doctor. And to conclude, I would like to ask if you have any type of advice or something to manifest or to show a project that we can start together collectively, since we are talking about not only about the reality in Latin America and how we are going to work in joint strategies. I would suggest, as previous times, and I have been able to, that we have to be in inverse, not the things go up down, but for patients associations it's important to raise their voice, to make an approximation, to have this close space to suppliers of educational services in health, and why not going to universities, looking for spaces, consensus, and not waiting for a university to decide and include at least to finish the subject. It is important to break the paradigm to have better results and quicker results. Sure. Well, Dr. Echeverry, I agree. In the same situation of Dr. Teran, I wanted to maybe talk about the super important role of parents associations, relatives associations, and caregivers in this regard, related to education, right? Because of my own experience, many times I have been invited by the associations to offer, let's say, conferences or courses, or just to share some time with the patients, with caregivers and parents, and to talk about in terms, let's say, in terms a little bit easier or simple without losing the scientific idea of if the disease, to understand what is happening to the patient. The patient learns, and we all know that all professionals that have been part of have been close to rare diseases, the ones that know about the rare diseases is our patients and their families, because they are the ones who have to live with the disease. They have to know how to deal with it and how to manage that. And the first time they can tell us how to transmit that knowledge and how to talk about those details. A professional in health should know about a certain disease, and for the role of associations is fundamental in this the education of these topics. Well, thank you very much, Dr. Now, Dr. Baxis, I can invite you to those that have the chance to be in front of the student and not expecting that the institution would be close to the association, or not expecting that the association goes to the institution. If I'm a professor or teacher, and I should have the initiative to go to the association, and all of that are part of the associations that are here, open the door to so we can develop this type of initiatives to any of the teachers without expecting for the bureaucracy and the agreements that in occasions are required from authorities. For that reason, I invite you that if you teach in any of the health areas, not necessarily featured physicians, try to put a small seed and reproduce this project that is enriching for the association as such, to be close to this young person that is going to be a physician in the future and show the needs. And the student, of course, is going to show empathy and develop that sense of empathy to do something for patients. So it is not that we should wait when there are big changes in our chair from the classroom, we can start those changes. Well, thank you, doctor. I will add only one thing. Not only to the students, but clinical practice. For example, we had the experience in Javeriana University and the Right to Disability Foundation to go to 5 or 7 cities in Colombia teaching physician staff from the director of the medical insurance in different regions what is living with a disability or having a rare or orphan disease. It works perfectly. We train doormans. The person that is the most important is that person in the door. She decides if you can go inside or not, and you have to beg to that person. They do not understand that situation. They don't know how to help. We train them. But what happened? It was financed by the Ministry of Health in Colombia, and the resources were over. But it should be permanent in every place, and these trained staff should learn sign language, how to talk to a person, how to direct a person that should be that have difficulties and disabilities, and not to change this person every 6 months and start over again. So if we need to start over again, we will do it, of course. But something that should be permanent in there. But in there, you can start a network at a Latin American level in which we can offer this type of programs. We can teach institutions that offer that provide health services. We can go outside of the academy and go to the clinical practice, to all the medical insurances. Thank you so much to everyone for your intervention and your contribution today. We have a lot of work to do, but many things were done. So thank you very much for all of it, and I would like to invite you after this conversation and work. We would like to invite you to the last session that we're going to see or analyze the experience of the 9 patient organizations that are here in the ERCAL platform and contribute to the work strategy. We're going to see the local reality. So thank you very much. In a few minutes, we'll continue.
bueno.
Okay.
Si pueden, que se sienten todos ya. Me faltan sillas, somos 9, 2, 10. Sí, yo me voy a sentar porque si no, no va a ser muy largo. 10, me faltan sillas. Orden, no, eso no importa, pero ustedes cuando yo los voy presentando, pero es orden alfabético. Parecía el alfabeto. Sí, pero no importa. Entonces,
passaram vários slides que eu tinha preparado. Então vou ser mais rápida.
acá, tú
Não todas, mas algumas. Então quando eu quiser passar, eu só.
volvimos.
We are back now. I know we are a little bit tired about this. This is our last panel, the last intervention of the day. The experience from the organizations and the local reality. I would like to start with Brazil, and we're going to start in alphabetical order. Ariadne, from Director of Raras Public Affairs. We have discussed that with that. So, Ariadne, please go ahead. So, dear everyone, most of the information was presented here by Dr. Roberto and by Tony. So, I will take advantage of this minute, of this time, just to call attention on some important situations and how to classify that. It was presented already. Uh, the list and the number of how we work with 13 million Brazilians and from 13 to 15 million persons with rare diseases. But it's important to understand that when we talk about rare diseases, we are talking about the impact of caregivers, and there are more than 50 million of Brazilians that were impacted by the reality of rare diseases. And yes, we don't have these graphs. These graphs are in English, and the idea was to present that in English. But I would like to call your attention on the fact that we don't have an official registry, um, and all of that generates an important impact on the process to define public policies and visibility of persons with rare diseases. And I would like to give you an example instead on something that we did to bring visibility. The Worldwide Day of Rare Diseases in all the country, all the associations move and start activities. We went to the metro, to the subway actually, and we talked about rare diseases, and there are 13 million persons that we tried to make visible the cause of rare diseases. So all of this is related to the coding. It was said this, but this is important to say it, since in Brazil we followed this international classification that passed through an inclusion process of rare diseases. This classification is fundamental for us, since it is the mechanism in which should be considered to build an axis that for us should be used for our group, only for you to know. And since yesterday we're starting to talk about that. We had an intense day about actions that we should develop together. And one of the most important actions is that, exactly that, to train this register, no, to have these registers that those are the parameters that we're going to make to perform our job. In here I would like to give you like an example to all of you. Those that join the rare diseases, I would like to know about the laws that exist in Brazil related to rare diseases. My time is almost over, but it's important for me to show you and share with other Latin American countries our experiences in the right way to improve. So this is Raras. That is important for you to know that we are 65 associations, and we are growing and growing. We are in the entire country, and would like to attract your attention to that. The experience of those associations, and we only have 15% of those associations that have less than 3 years. And we also have a lot of experience on the research programs. And, well, I will continue. It's 5 seconds to finish, and I'm going to be punished. Well, this graph was already presented, and I wanted to show here the initiatives that were discussed, the Casa dos Raros, but I wanted to show you the last graph. That was not my presentation, sorry. But that presentation was updated. I don't know what happened with that. But I wanted to show you, what I wanted to tell you to conclude is that in terms of opportunities, we have many things to discuss, to deliver it among us, and to find out what works in Brazil and what can work in Colombia, what is happening in Peru and what could work in Colombia. Sorry about the time and for being really quick. Thank you, Ariadne. Well, and now we can start with Chile. I would like to
present Alejandro Andrade again, President of the Federation of Rare Diseases. What about the control here? Hello, you already know me. I'm not going to describe myself again, not necessary. But in Chile we don't have any an official definition. I said that in my first definition. Or rare or least frequent disease is not something to be concerned about. It's important to work in coverage and diagnosis instead of defining. That definition could arrive later, but we propose that we can say that it is not proposed by us, but we worked for a while in a national proposal for the national plan. 150 associations, 150 people during summer, and it was to cover heterogeneity of the population, like geography, aspects related to the environment that can affect everyone. We can start that a rare disease is not genetic. Some others are related to metabolic situations and contamination in the place. So, incidence in our country, Chile has about 1 million people. Let's say a prevalence calculation, because we don't know how many they are, but we developed a registry from our first cadastral number. This number can be found in Amazon. This is less than a coffee. And this registry was able to show that at least more than 72% of the population answered to the survey were women. And from them, they are from 31 to 59 years old. So, Chile does not have any official registry, and the idea is to have a national plan in our book. Chile does not have a special model to code and register rare diseases. Sometimes when I was preparing this information, I would say no, 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 and many no's, but maybe that condition or this situation, it's a great opportunity to build many things. Now, what regulations are available now? I have to clarify something. None of these regulations are specific for rare diseases. Instead, that they have some other uses, and among these uses they come to rare diseases, and one of them is HES, which gives coverage to two types of the diagnosis and treatment of hemophilia and cystic fibrosis, and the other one that has 16 rare diseases in the list. And a little bit lower down, the National Program of Complementary Feeding for metabolism errors, and it has a star in there. We have a new neonatal screening program, and that for that reason we started in the Chilean Ministry of Health, and we are going to start 26 pathologies, and it is important for us, and we want it to improve more and advance more, but it would be worse to do nothing, and the amount of patients in the country could not include all of them, and I put the big three umbrellas in Chile, which is the Chilean Aggregation of Patients Alliance, FECOER, and FENPOP of Chile. That is, FENPOP is concerned about the coverage in not frequent diseases. So there's a presentation, permanent presentation, and in this image you can see our invitation for the presentation of the draft of law from the civil society. That is located in the legislation in the Health Commission of the Senate, and it requires that the government support the public expense articles, but you don't have any pressure on our government. But if you can tell our president and Twitter, present the indication, is enough. So, well, everything is done, and we are next to the subsecretary of public health that finishes term, and the campaign was it should be the same. The last year without a regulation, without a definition, it should be the last year, finally. National programs of research. I included the seminar from the Chilean University and less frequent, led by the University of Development. And specialized centers, the diagnostic odyssey is 7 to 12 years, 7 years to get to the specialists that are focused on, or that are located in the central part of Chile. So the most difficult is going to be if you are far away from the center of the country. Our program, cadastral and registry consequence, genetic consequence, and have a diagnostic reference, and the CIO that I have to clarify is not center but is service of information and observation for people and families. And it looks for guide families that are in contact with FECOER to know what they can do in regards of public policies, to if they require an attorney, and opportunities that we have as a country. Situation of our Chilean model nowadays is in crisis, a great opportunity to move forward in the space to get in the legislation space. We have the option to present drafts to the law and build solutions for the needs the patients have, and budget allocations, and to start in the neonatal screening. And for that reason, it is important to push our government so they can start using the money that is allocated for the budget. And we wait for you in Chile. Thank you so much. Now it is Colombia.
Perdón, Alejandro, me estoy anticipando. Y ahora voy a presentar.
Now I'm going to present who we all know, Diego Gil Cardoso, Executive Director of FECOER, the Colombian Federation of Rare Diseases. Thank you, Colombia. Well, a definition of rare diseases, we call them orphan diseases here. Well, as you might know, Ley 1392 of 2010 defines them as those diseases that are chronically debilitating, that are life-threatening, that are severe, and that have a prevalence of less than 1 in 5,000. 3 groups: the rare diseases, ultra orphan, and forgotten diseases. We estimate that around 4.5% of the population in Colombia is living with this type of diagnosis. We estimate that it's around 2 million people that might be living with a rare disease. We have a national registry of patients that started in 2013. It started with a census of patients with hemophilia and has been growing. The information is in an integrated information system that is administered by the Health and Social Protection Department. We had 8,000 plus people last year, with a top 80,000 people last year, with multiple sclerosis being the most common rare disease. We have an inventory of diagnosis that has been updated 4 times in 2013, 18, and this year we had another upgrade that gave us 2,200 plus pathologies. We have a process every 2 years to be able to add more diagnoses to this list, to exclude or modify the pathologies in this list. The updating of this list of RDs includes the processing of the nomination, review of scientific literature, synthetic and clinical presentation of the information gathered, and presentation by experts on panels. Colombia has a regulatory framework that is pretty robust regarding rare orphan diseases. I could highlight the framework law of 2010 that recognizes these type of diagnosis as being of special interest by the Colombian government. There is a definition. We have the National Work Table on RDs, that is the main participative space that we have in our country, that was formalized recently. We, of course, have the beginnings of an information system starting from a degree in 2012. a national patients list. Another threshold is a statutory law in 2015, where we recognize people, RD patients that are subject to special protection by the state. The resolution on reference centers from 2018, National Registry of Patients, the law on neonatal screening that we have to yet implement, and we are working through different regulation on financing medication. The FECOER is the reference for patient organizations at the national level. FECOER has been the main social actor that has promoted drastic public action in rare disease in Colombia. It is an umbrella organization that is made up of 40 members. Most of the leaders of these organizations are here with us today, and we create synergies with the different actors to be able to promote these changes. There's permanent representation in these work tables, which are made up of 14 members, of which 5 are representatives of patient organizations. 3 of them are from FECOER. The Ministry of Health and Social Protection submits the results of the work to consultations. Right now, we are working through the 7th Commission of the House of Representatives, which are the ones that convene us to the public hearings because of FECOER has a important social standing. We've made improvements in research, but there's a lot of work to do. In terms of access to specialized centers and comprehensive care centers, there's a regulation since 2018 that talks about reference centers for diagnosis and pharmacology, but we have to eliminate some barriers and promote incentives for these institutions to come online. I would like to share an initiative. There are several, but we just developed a collaboration project for a model for caring for RD patients. It was a collaboration project among many entities. You see the logos of these, where we identified barriers, and they have 7 lines of action that talks about integral, comprehensive care, differential focus, new technologies, and standardization of the care path. These are 11 opportunities that we identified at the work group on RDs. To be able to sum up these opportunities, basically what we looked for is that most of the regulatory framework that we have is implemented, strengthening what we have in terms of registries, reference centers, knowledge management, not only for healthcare professionals, but for civil society in general, and work on financing. That is also a very important aspect. Thank you. Now we will move on to Costa Rica. Ronnie Garro is the leader of the network of associations that deal with RDs in Costa Rica. My colleagues, yes, made me the director. We use the WHO's definition insofar as we consider the threshold of 1 in 10,000 people. In terms of incidence, we are using the estimated incidence from Pan American, from PAHO, and also we use around between 300 and 400,000 people, and we have already identified around 400 people, but this leaves hundreds of thousands of people outside of. We do not have an RD registry, but one of the initiatives that we have is to start to work on this registry to be able to have reliable data that, as we have seen throughout the day, are key to be able to start to establish policy so that decision makers can have information. This is the inventory that I just mentioned of the different diseases that we have classified. In terms of legislation, we presented months back a project called Comprehensive Care for RD Patients. It needs to be approved yet. Right now, there's very little political will to pass it. Also, some technical issues in the bill. What we are doing now is leveraging the political constitution, Article 21, that human life is inviolable. So based on this, we've gone to the courts to demand health care for RDs. And the members of the network so far and for the last 15 years have presented 7,000 claims, and most of them have been won. Unfortunately, over the years, the authorities have learned how to include legal technicisms to deny some of these suits. Right now, we are working at a project that is aimed at acquiring high-cost medications to help through a special fund, Social Security of our country. We have mapped more than 50 groups of patients. Since there's no formal body within the Costa Rican state, obviously we do not have any representation. Yes, there is no direct research program, but we do have some research centers that tangentially or within their line of action cover some of the RDs that we have classified in Costa Rica. In terms of care centers, we have the San Juan de Dios RD Clinic, which is the dean of hospitals in Costa Rica, is the oldest hospital. However, it's very limited in its action because it has been done out of the heart of doctors and professional associations, more so than because they were given resources. And the National Rehabilitation Center, that within their mandate they service RD patients, but within the concept of rehabilitation. In terms of initiatives, we have continuous learning programs on RDs, training and empowerment. Right here we are talking about people that suffer one of these diseases, their caretakers, their family members, to be able to have them claim their rights to health care. Obviously, we accompany timely care, the initiative that I just told you about of the patient registry. We are launching an IT platform as a news sort of portal. And through ERCAL, we are going to invite you all. And we are also drafting a bill for high-cost medication support. Among the opportunities, we've also heard throughout the day on professional training, both at the undergraduate and postgraduate levels. So the Aula Clínica project is a huge opportunity for us, and we want to start with undergraduate students opening up space at universities to be able to present diverse cases, of which we have many, to bring them closer to the world of RDs, the national patients gathering that before the pandemic we held one and we haven't been able to do another one. It is an in-person event, the open consultation, which is to have specialist doctors working together with young doctors and young students, exploring diverse cases. We are working on the first forum on medication and the regulatory agency, which is tied to the high-cost medication program. And we are defining the National Medical Humanity Award to motivate doctors to get involved in RD, because we have some angels, but they are still too few.
Muchas gracias, Ronnie. Pasamos a Ecuador. Me gustaría presentar a Félix Galarza, presidente de la Asociación de la Federación Ecuatoriana de Enfermedades Raras o Poco Frecuentes, FADEPOS.
Bueno, muy buenas tardes con todos.
Good afternoon. The realities in Ecuador are not far from the realities in the region. We estimate that in Ecuador we have 7% of Ecuadorians that live with an RD. This number is based on the WHO estimates. We don't have clinical or statistical information from public or private hospitals that demonstrate that RD patients of certain type of patient have a consolidated registry at the national level. And we do not have mortality rates from RDs. We need more specialists. We need more immunologists, endocrinologists. Most specialists are in private healthcare. More than 70% does not have access to only one consultation for their disease. More than 70% of specialized genetics tests are not carried out in our country because we lack the machines and the personnel and the high cost. The Ministry of Public Health since 2011 has a list of 106 diseases. We have catastrophic diseases there. In Ecuador, we have catastrophic and rare. Catastrophic are acquired, like cancer, HIV, diabetes, so there's no list of RDs in Ecuador. The Ecuadorian Federation, FEPOP, carried out a brief study in 2020 with civil organizations, which told us that there is an under-registry of rare diseases due to a lack of specialists and proper diagnosis. In October 25 of 2022, we presented the first registry of RDs. We managed this because for several years these organizations had been calling for it, but it hasn't moved forward. We know that there are 1,200 people registered on it, 500 partial registration, and 120 something that have been fully registered. So this system is not user-friendly. The patient needs help on this because it is not a user-friendly tool. You need help. Currently in Ecuador, what we have is based on Orphanet. So the Ministry of Health is using this Orphanet registry to classify the pathologies and see which is the most prevalent. We are awaiting those results. There are certain places in Ecuador where we know there are a lot of inbreeding. We have seen some pathologies there, but we haven't had a consolidated list of these populations or diseases. In Ecuador we have...
Ustedes van a dejar cosas acá, ¿no?
¿Perdón?
Van a dejar cosas aquí.
No, estamos ocupados. ¿Qué pasa? We have a constitutional recourse when the government denies care. This is the only thing that protects us when there is a high-cost medication that the government needs to supply. We have had more than 20 rulings on this, but the government is not enforcing it. It is a uphill struggle. We need to do sit-ins, we need to protest. So we also have an organic health law, or Law 66 on RDs, but they just included us among the catastrophic diseases. We don't have our own law. This is why we are asking for it. Natalie Viteri asked for it. We want a perpetual budget for RDs, because the general budget gives us an amount that is insufficient, because the law can be beautiful, but if there's no budget, it doesn't work. We are asking for this law to have a perpetual budget that can be, as the fight against cancer, that has money flowing in from each cash transaction. In Ecuador, we have dozens of organizations that have been fighting for all this time. We have 15 on the slide there. We joined together on this fight. Some are part of the Federation of RDs for Ecuador. We joined the catastrophic disease movement, and with other organizations that at one point have the same goals. We fight for the health of Ecuadorians. We support each other and we help each other. That allows us to grow as a country. We have the experience, but it's not being leveraged by the lawmakers. We can tell them what we need, what we require, and this is where everything is born for the support that we need. Civil society organizations have become more visible in lawmaking. We have many work groups. They call us to these work groups. And this is what is happening with the single registry for RDs. We know that there's a ministerial agreement on this, because when the Ministry of Health is replaced, everything falls apart. We have been working on this for 6 months. They do not want to honor their agreements because they don't want to talk about numbers, because if we talk about the real numbers of RD patients in Ecuador, they have to assign a budget, and the government doesn't like to assign budgets, not on health anyway, or on education. In 2018, we created the Sehemed Center. Unfortunately, Sehemed hasn't worked. It is a good initiative for us, but it hasn't worked. Now they called us to new meetings. They said that they had budget. We hope that we can get at least 32 classified diseases, and that this center is refurbished and assigned some budget. In Ecuador, we do not have specialized centers for RDs. We do something through Enfermedades, I just told you. To sum up, we have several initiatives. As a federation, we have our flagship project, which is an informative guide to know where patients are located, where doctors are located, where reference centers are located, hospitals of first, second, and third and fourth tiers. We are launching this guide together with an organization that deals with catastrophic diseases. So that's our flagship project. Opportunities are manifold, but we cannot capitalize on them. I think that all of the region has the same challenges, and that's why we are here, to learn from each other. Learn from those who have done it, and thank you for your time.
Muchas gracias, Félix. Y ahora me gustaría presentar a México. Jesús Navarro, presidente de la Organización Mexicana de Enfermedades Raras, OMER.
Muchas gracias. Bueno, la historia de mi vida ha sido esta, casi ir al último. Ya todos están cansados, espero.
This is the story of my life being the last. In summary, in our country, regulation started through Article 2024 bis and 2024 bis 1 that mentions RDs and orphan medication as a right to health, as part of the right to health. But it's included in the National Health Care Plan. It's not in the Constitution. We adhered to this statistic of the WHO because we do not have adequate registries. In Mexico, we think that it's 5% of the population, but we might think that it's around 8 million people around the country. The National Patients Registry is led by initiatives of patients organizations like FEMEXER, FUNSALUR, REMEXER. We heard from the doctor that allow us to get epidemiological and statistical data on our patients. This is one of the projects that we need to drive forward. We need to think that they are not all linked to a registry that has the CEI 10 or 11, but we adhere to the International Registry of Orphanet. It's a very organized index and is widely accepted. The inventory of RDs and people with RDs from FEMEXER still has many gaps that we need to fill. The regulation of the General Health Law introduces the concept of RDs and orphan medication that have been an introduction to some of the therapies that we have in Mexico today. We are reviewing two new regulations that regulate the national health law so that we can create specifically the law on RDs. We hope that we are the first state that has regulation, that has budget, and that there's something that we are working on, but it is very difficult to explain in 4 minutes. FEMEXER, OMER, and ANAER have been the only patients organizations. It's impossible for me to place the 200 logos of the patients organizations, but because they represent people and their families. We recognize two research programs. One is a federal program, but there's another research center that is led by the Biomedical Research Center in my state. There's another initiative in the Universidad Autónoma de México in its diagnosis center that is also has a nascent patient registry. It's difficult to explain our network of specialized centers because since our healthcare system is very diversified, we have named most of these, but only for the population of that state, not for the national population. The initiatives include the reform to the general health law and the modifications to the law due to metabolic screening led by Jacqueline. We have many opportunities, and as the doctor said, the UN resolution has been adopted and have been working with our own commission for the SDGs at the state and federal level, dialoguing with them to present intervention models where they have the responsibility of signatories to this resolution before the UN. Yeah, it's an opportunity to be able to position and make visible and create a panel to explain the opportunities for patient organizations throughout the country. Thank you, everybody.
Muy difícil, 4 minutos.
Muchísimas gracias, Jesús. Y bueno, ya nos quedan solo 3 países, así que esperemos que tengamos todavía la atención para...
Now that we still have your attention to listen to you. In Panama, Vanessa Palencia, Mexican work at US Panama, which is the National Federation for Rare Diseases. Good afternoon and thank you very much for your attention. I'm honored to represent my country and all the patients organizations that are part of it. For Panama, it is calculated that about 299,000 people are affected by a rare disease. And we know that this number is higher because there is a sub-registry. There is no single registry for a rare disease, and we are promoting that there is a census at a national level as Federation with the initiative with the Foundation Aid Panama and the rest of the member organizations. We are going to boost that, and we have another coordinator of rare diseases, and fortunately in this government we have had more than four, and with a lot of commitment and motivation it was approved to include this registry, and we are supporting as well as other organizations to work with that. Therefore, in 2014, the law for 28 established the law of rare diseases and typified 10 groups that have a code for MINSA, and in time it increased with the information from the patients organization. And the law tonight was amended last year, and we hope that it could be executed. We're appealing to inject a budget of 10 million to start what the law, very nice and great, is going to be to make in favor of rare diseases, people affected, but with money. Without money, we cannot do anything. In Panama, there are two umbrella organizations, as you know. I'm part of ACER, and one of the initiatives that we started was to train these parents as leaders, mothers specifically, as a group of patients. We are strengthening the association tissue. We were able to see an after and a before, to take the flag, embrace new people with new diagnoses, and for us it is a great improvement. We're working on the corporate image from each of the groups, and taking part actively on all the initiatives in favor that the rare diseases in Panama would be executed. Permanent official representation for patients is established by law, and it was modified because there were a lot of gaps. Nowadays, there is a leader or representative of the organization, replacement, and a period of maximum 5 years of representation. That is, they are elected by voting. We don't have any research program more than these initiatives that organizations perform with their advisor physicians studying or evaluating the reality of their own communities. And we don't have any specialized center. We have centers for the attention of health that are take care of the specialties and therapies, but there is no center related to rare diseases. And as I told you before, these are the initiatives that the patients organizations have in a lonely way, and together. And 2020 we started with groups of patients to start a great visibilization campaign of rare diseases, and I have the privilege that before in Panama, talking about rare diseases was something unknown, but nowadays it is not like that. Thanks to the job and the effort of many associations and a huge group of more than allied doctors are volunteers for organizations, and it supports us a lot for the specialists than many countries do. And collective campaigns, and what part of that is being part of ERCAL. We learn from the experience of our partners, and we trust that these regional projects that we dream and we talk about will be executed to defend and achieve the defense to the right and health. Thank you.
Muchas gracias, Vanessa.
Thank you very much, Vanessa. And now we go to Peru. Marilena Almendaris, the Executive Director of the Rare Diseases, Peruvian Association of Rare Diseases. So, Marilena, please go ahead. Well, thank you so much. The Ministry of Health had 8 criteria to define a rare disease, and there was a prevalence because there was no epidemiological distribution on 1 per 100,000 inhabitants and 1 per 3,500. So this prevalence placed on the law does not determine anything. So that is the definition in Peru. And on the other hand, we use the CI-10, and the state has recognized up to 2020 546 diseases. They could be 1,207 identified illnesses, and FEPEP has identified 287, and they could end in distribution of disaggregation of 887 diseases. And about this approximation, we talk about 2 million to 2.3 million people, including that the most transparent number on the Ministry of Health, that there was a population to apply the third dose of vaccines of 144,492, and then we had an attention map that evidence that 68% of the population should be assisted in the capital due to the situation in the public system. And the population in Peru is diagnosed and institutionalized. This is the prevalent on chapters, and FEPER through these years has built a group of epidemiology group that we should consider that the patients are close to the federations notifying the illnesses and population, and this is the population the federation has identified that is more than 100,000 patients. The first one is the ranking of the prevalent chapters, and the Ministry of Health has created the last single registry that includes at least 1,000 patients, 1,100 patients. And in here, the society should be part of this registry, the patient and this federation, that it should be a higher registry. And then we talk about for the families for FECOER to obtain like a law, a regulation, a national plan, and a regulation. I won't speak about what it has been issued, but we have a law of a screening for five different um, screening and we started differential evaluation models, and we have an initial designation of 88 national coordinators, which is a group that that have to be included for the test, or to decentralize the management on rare diseases. And finally, there was a last document for the registry of medication in phase 2 event for a quicker process. And we have harmonized criteria, make it flexible, and communication among others. There are more than 60 organizations sorted for rare diseases. We put them on the website, but if there any patient with any pathology can endorse to any of those initiatives. And there is a formal mechanism, which is the National Health Council, and we have the sub-management of the orphan and rare diseases, and make permanent mechanisms has been the meetings with the Federation, mechanisms that include global thematics that we should take part of. And that is important to create a permanent board to give sustainability and continuity to the agenda. National investigation programs, some institutes, some public and private universities. And we don't have any innovation and technology. There is no national genetic or genomic and biobank institutes. And in 4, we had 4 international studies. So, in opportunities, we have a regulation framework for rare diseases. There is a growing interest for knowledge and mobilization related to rare diseases in our country, and multiple stakeholders that are taking part of it in the municipalities, regional government, companies, different industries. Among different stakeholders, there is a specialized commission for the evaluation of differential evaluations in Peru, and 88 coordinators that can help to decentralize the human resource that should include capacities, and it's recently starting. So, more than initiatives, the Federation considered that it could be an important space to work with the government. And as a recommendation, I would say that we need to improve the standards of some institutions, like the general management of medicines, that is category 2, and development analysis, and related to the patient route, to reduce time and make flexible processes, and to include prioritization, humanization, and capacities in every environment. There is a lot to consider the rare diseases in attention and make human and all the system and the sanitary system, even the society. Thank you.
Sí, muchísimas gracias.
Thank you very much, Maria Elena. And lastly, Dominican Republic. I would like to include Roberto Rodriguez, Vice President of the Patients Associations at DAPA. Okay. There's a lot of data, information. It makes me happy because I have to be seated where I'm seated now. Definition of rare diseases is bad, and the legislation. In the Dominican Republic, there is no mention to rare disease or least frequent or complex. Not because of data only, but we can collect was National Patients Registry. So what we were able to
collect our information. Our information is related to the patients' associations and physicians, and some physicians are making are doing magic. A system that does not receive any support, and all the data and information, incidents, and has been taken from what they supplied, and what the associations offer to us, despite that here we don't have any data to trust. But what we collected formally, we can say it is 2,450 patients with rare diseases, based on the 7% you, the WHO organization says, the sub-registry and the sub-diagnosis that is present in countries like ours. It is very concerning how to plan, how to make policies and plans and projects. It is difficult, so those patients do not exist. So it makes us actually that our main goal, it's we have presented and a legislation request for rare diseases that will be presented, and we have a senator in the national district that Farid Raful that adopted the project, and we are in this moment working to organize the work boards in the Senate and the deputies chamber to start the draft for the law. So that would be the first presentation or actual presentation of rare diseases in this place to talk about this situation, this topic, amount of patients in the country. At APA, we can say that we have grouped about 30 organizations for patients with rare diseases, about 25 or 30 relatives that have not reached to be formal, and they are under the same umbrella of ADAPA. So the permanent representation, nothing. And basically, as I told before, the representation that is going to be present from ADAPA in the work board, in the Senate, and the deputies chamber. No national research program. Well, I should clarify at the beginning, we have physicians, we have staff that work with research, but individually and with not a lot of data and no publication to share it. Access to specialized centers and comprehensive attention networks. Well, we can say in the centers with these patients can be received because the specialists mention them and they say it in the sponsorship in those places with the support of physicians, geneticists that are there. The few of them have been able to start with the concern and in the hospitals in which we can start little by little talking about screening, about the possibility to create um, the list of rare diseases that is there, but all of it we are still working on it. Sure, initiatives definitely. What ADAPA has been during the time it has been there, but the first initiative, there has been some other rare disease associations to influence on public policies this way. ADAPA has been the first initiative in this regard, grouping relatives and associations with rare diseases to give visibility to the society. Also the inclusion in the general health system because they are not there. We created within ADAPA a network in organizations and relatives And as I told you before, we are working to create the law of rare diseases opportunities due to reasons and difficult situations, but we were able to have a great acceptance within the institutions, the decision makers, when we started with the initiatives for rare diseases. That was the first step, and that was very well accepted. And we have the National Disability Council that coordinates the process for public policies in this area to guarantee the inclusion of people with disabilities in a perspective uh, that includes rare diseases and the UN resolution that we should not speak about that anymore because we already discussed about that many times. And from that, in a country, despite the resolution from the UN that was signed in our country, we don't have any access to rare diseases. And lastly, um, this group of people that we have reunited here, thanks to our friends from ERCAL, our friends from ERCAL, we get a lot of hope as a country because definitely, I believe that we all look for a lot of information and data, but there are things that are still missing. We need some other things, another draft, but everything starts. This is an important starting in the country, and I thank the team very much. Thank you so much.
Muchísimas gracias, Robert.
Thank you so much, Roberto. And I would like to thank all of you, all the patients groups that are present here, that presented their reality, and also prepared a collaboration network through the network that we started with ARCAL, that were the preparators of the agenda in this Congress. So that way they are taking part actively in the working strategy in the ERCAL platform to generate collaboration projects at a regional level. In special thanks to Diego from FECOER, who generously helped us to start this Congress and open the doors in Javeriana University and all the resources. Um, and without any further, I would like to thank everyone to be here, and we wait for you tomorrow. All cleaned at 8:30 for a shorter session that is going to take place tomorrow. So tomorrow is going to be only up to 2. So we have panels, and so thank you very much for coming and joining us today. Have a wonderful evening.